Well, good morning. So I'm Andrew Morris. I'm Director of HDR UK. What a great pleasure to welcome you to our inaugural UK Health Data Research Alliance Symposium. It's a busy day. I looked at it, there's over 35 participants and organizations contributing to the agenda today, which I think is absolutely terrific. So I'm just going to say a few words to set the scene. I think this is an important day because it's the first time that we've mustered as a team. We've brought together alliance members, the sprints who are still sprinting, the hubs and other partners to celebrate what we've achieved so far with the Alliance and the Digital Innovation Hub program, but importantly to horizon scan and state our ambition for the future. And I think the agenda today just demonstrates the energy and partnership working that you've created as part of this program. Can I thank the Welcome for hosting us? It's a terrific venue, isn't it? There are no fire alarms today, I understand. So you muster. Fran, where do you muster? Right. I think, okay, run then. Okay, that's it. So there are no fire alarms. We are actually oversubscribed. So apologies to those who are on the webcast. We've got many folks, scores of folk on the webcast. I said to Fran, we need to book Twickenham next time for this meeting, and I'm sure it's more entertaining than what they usually deliver there. Why are we here? So harnessing health data for research and innovation purposes with follow-through for patient and public benefit is intensely topical. You know, before the election, we saw it in many broadsheets, even the tabloids. So it's intensely topical. You will recall that our mission is to unite the UK's health data to enable discoveries that improve people's lives. And it's essential that if we're to do this in a trustworthy way, that society, both individually and collectively, owns the approaches adopted, so that we really can hand on heart say this is for the benefits of patients and populations. So I think that is a key theme today. How do we do this in a trustworthy way? And I'm delighted that Angela Coulter, who's recently being appointed our chair of our Public Advisory Board, will be kicking off today. However, if you do an environment scan, these are just a few logos of the complex landscape. We have some outstanding organizations and initiatives in the UK in the health data science space. But a major challenge we face is interoperability. How do we work across systems with no additional effort? And this is a huge challenge. If our vision is to be able to run studies on up to 66 million people, how do we organize ourselves so that we're frictionless in how we do business? And that is a huge challenge that we haven't tackled. It's actually a global challenge. Recently we've had discussions with Singapore, with Canada, the US, Australia, and everyone's grappling with this challenge of interoperability. And it's important because many of our researchers and our innovators, if you believe Forbes and the NIH, they say that our researchers, our innovators are spending 80% of their time collecting, accessing, and cleaning data. And they say it's the most time-consuming and actually the least enjoyable part of their jobs. 80% of human resource is spent before you actually ask the question. So surely we can do better. Wouldn't it be great if we could give them 80% of their time thinking, asking the best questions of the data? Mike Driscoll termed it data munging. So our challenge is to reduce the amount of time folk are having to data munge. And that's really the purpose of the Alliance. We're a year old. We always say we crawl, we walk, we run. So we're just coming out of the crawling phase, but our ambition is to create an alliance of leading healthcare and research organizations. And we want to unite to establish best practice for the ethical use of UK health data for research at scale. Because going around the UK, what I see is everyone's looking at the same issues. There are endless committees all looking at the same issues. So why don't we pool best practice? This stuff is pre-competitive. So why don't we pool best practice, learn from Genomics England, you learn from the UK Biobank, learn from the stuff that the Health Informatics Collaborative funded by the NIHR has done, and work in partnership with NHS Digital, NHX and OLS to establish a portfolio of best practice that we can all subscribe to. So we don't want endless committees. We want to learn by doing, and we also want to develop in the open and learn from best practice. And one of our principles is to publish everything transparently. And that's why we webcast everything that we do, because it's important that we do this in the open. And we will make mistakes. But I think if we commit to transparency and learning from experience, we'll actually make progress. And we will make mistakes. So things which are worrying me at the moment is, how do we engage colleagues and learn from colleagues in the North meaningfully? How do we make sure this is a UK endeavour and not just one of the home nations dominating? So we will together, I hope, grapple with these, what Caroline calls knotty issues. So today we're going to look at the engineering of how we do this well in terms of data access, data quality, sustainability, commercial models. How do we work with industry in a transparent way in the public interest? Public engagement. What is our technology strategy for a federated infrastructure? And lastly, this secret source of interoperability. And the way we've designed this is that we've been inspired by other collaborations, mostly in other sectors that have worked well. Because if you look at the banking industry, they have SWIFT. If you look at telecommunications, they have GSM. I can phone home from Australia because the telecommunications companies subscribe to a way of messaging together. So I would argue that no one organization in this room possesses all the information required to address every health and well-being issue facing society. So we need to partner so that we work across organizations with trusted expertise, governance, and interoperability. And our alliance is a neutral UK cooperative that will be defined by you, because you are the community of data controllers and relevant experts across the UK. Why is this important? Always think of impact. So this was in the Lancet on Saturday. It was a deep learning for prediction of colorectal cancer, because actually our prediction of outcome and stratification of who needs what treatment is still in the foothills of where it needs to be. So they looked at 12 million image tiles, so it was multi-dimensional. You can have these slides, Charlie. You don't need to photograph them. Are you an author? Maybe that's what it is. So 12 million unstructured data, 4 cohorts, but you can see that by using 10 models of deep learning, there's the potential to actually have better prediction for the person sitting in front of you with newly diagnosed stage 2 or stage 3 colonic cancer. But to do that, and this was an accompanying editorial in Lancet Digital, the use of diverse population data will be critical. Sharing data between institutes and regions is becoming widely accepted as a necessity to AI research. This required data from Norway and the UK. So how do we do this easily? How do we do this so we don't spend 80% of our time doing it? Welcome NIH, National Cancer Institute, are saying that any data gathered from any funded project must be made available. So let's get on the front foot, the UK, and make this happen in a trustworthy way. So today, welcome. We're very proud to be working with you and to learn from you as a community engaged with building this UK health data research infrastructure. We think you've delivered a lot, actually, and I apologize. Caroline insisted the hub milestone was the 31st of December, which was a little bit of a showstopper. But we should celebrate what you've achieved. We want to gain inspiration and learn from each other, not only in the UK, but internationally. But importantly, how do we help shape priorities and plans for the future? So get to know each other. Let's grow this into the GSM standard. They meet in Barcelona every year, 85,000 people. So I'll finish with Osler, often referred to as the father of modern medicine. He was a Canadian, but he was also Regis Chair in Oxford. He said, the best preparation for tomorrow is to do today's work superbly well. So I think what we want to do is to do today's work superbly well and create a community, an infrastructure, a relationship with each other and the publics to actually do something which I think should be transformational. So thank you very much for listening. We're going to move straight on. So Caroline is going to chair the day, but my final responsibility is to introduce Angela. Oh, there you are. Angela Coulter, who, as many of you know, is chair of our public advisory board that has proved invaluable as we've designed and engaged with you and the public about how we do this in a trustworthy way. So please, can you join me in welcoming Angela?
Thank you very much, Andrew, and welcome, and thanks for listening to me. One of the things we want to do superbly well is patient and public engagement in all this endeavour. And I'm going to just talk for a few minutes on some key themes that I think we need to get right. There we go. So these three. First of all, how do you involve people? Secondly, how do you build confidence in the use of data? And thirdly, how do we demonstrate clearly public benefit? Now, none of us on the Public Advisory Board claim to be experts in any of these things. We are very committed. Many of the members of the Public Advisory Board you will have already met. Some of them are linked up with hubs. They've been attending various meetings and they're dead keen. But none of us claim that we have all the answers. What we are very committed to doing, though, is to learning with you and learning together. So we had a very good meeting the other day with representatives from the hubs. Each of the hubs has now developed a plan, a strategy for engaging people in their activities. And they produced some really interesting plans. What was really great, though, was that all the plans were completely different and everybody was really keen to carry on meeting in this way so that we could refine all of it together. This is a nice example from Data Can. It's just one example. I really like the way they set out their principles for engagement. Ensuring patients are included in all our work, ensuring that the engagement is representative of the diversity of the British population, ensuring that clarity and transparency, trying to focus on the things that are really important to ordinary people in users of a health service, and empowering people to be involved and engaged. I mean, I would add one more thing to that list, actually, which is measuring impact. We need to know what difference all these efforts to engage people in the work makes to the work itself and the quality of the work. Then there's the knotty issue of privacy and security. It seems hardly a week goes by without an article in the press about raising concerns about health data privacy. There was one in The Guardian only yesterday, some of you may have seen. We have to be able to explain what the safeguards are, how they're being observed, and why they're in place and why the data is needed, why this trade-off that we're trying to persuade people is necessary, the trade-off between the privacy of their own health data and the potential uses of it for benefiting the public, why that trade-off is important, and how we're making sure that there are safeguards on both sides, both that the data are kept securely, and safely, and that insofar as is possible, they're anonymized, that respect for people's own individual personal security is absolutely uppermost in all of our minds, but also that we're going to use the data responsibly and well to produce really useful research, not just lots more kind of repetitions of other research and demonstrations of things we always knew anyway. And I hope that in all the sessions we're going to have today, that will remain uppermost in your mind, and that any ideas that you have for doing that will be shared, because I think we are potentially vulnerable to people who put greater emphasis on one or the other of those two ends of the spectrum and potentially damage the other end, if you see what I mean. And the third theme is demonstrating public benefit. We have the huge advantage of being able to build on the work of organisations like Understanding Patient Data, who've done a huge amount of useful research into what people think about health data, how they like to understand it, how it can be explained. There are wonderful little video clips on their website, which are free to use for anybody. So rather than reinventing wheels, we should use all this good work that's already been done. There's also a lot of very interesting research going on at the moment into what the public thinks about health data. Again, under the auspices of Understanding Patient Data, but also One London is doing some really interesting stuff, which we may be hearing a bit more about this afternoon. But in thinking about this issue of public benefit, it's no good saying we had a great article and wasn't it wonderful The Lancet published it. Yes, that is wonderful. I know, I've tried to get articles in The Lancet myself. But most people don't read The Lancet. Most of the public wouldn't have a clue what's in there and wouldn't be able to understand it if they did, because it's written in horrible academic jargon often. So we have to go much further than articles in The Lancet. We need to communicate in ways that ordinary people can understand. And that is a big challenge, but a challenge that I'm sure everybody here is up to. We need to demonstrate public benefit so that we can explain to people why we want to use their own personal data for this endeavour. Thank you very much.
Thank you, Angela, and hello everyone. I'm Caroline Cake. I'm the Deputy Director and Chief Operating Officer at Health Data Research UK, and fantastic to see so many of you here. I know many of you already, but there are a few faces that are new to me, so if we haven't had a chance to meet properly yet, I hope to catch up with you during the different sessions today. So we have a very fun and exciting day ahead of us, and there's a lot we're going to be doing, and think of today as actually being almost kind of representative of actually how this whole endeavour is coming together. So this is bringing together people who get a lot of stuff done, bringing them together and looking at how much we can do collectively and how much it all adds up together. What I'm going to do is share a little bit today through a couple of slides of showing what's already happening across all the different pieces you're doing. So each of you will be very focused on your specific area, but actually when you start to see how much it adds up, we start to see how the momentum can really build across this. So I'm going to go into just little introductions into that, and then we're going to actually hand over into Jerry, who will go more into the gateway, Ben, who'll be talking about the hubs, and David and others and team members talking about the Alliance. And so we're giving you a bit of a flavour of a little bit more as to what's been happening in each of those areas. So this sets out how the different pieces come together of what we're doing. So if you think of how we're kind of thinking through of HDR UK, we're kind of distilling it into three things: uniting health data, improving health data, and using health data. And then if you see things, so those of you involved in the Alliance and the Gateway, that's around how the data is brought together in a trustworthy way, as Angela's very well explained earlier. Those of you involved in hubs, about how you're actually bringing together the, improving the data so it actually can be usable for different people. And then those who are involved in research and discoveries, how that data is actually being used, what questions are being asked, and going to Angela's point around actually what benefits are actually being delivered from this and what value is being created from there. And all of that wrapped around with public trust and benefit, building communities such as today, and then the underlying governance that makes this all possible. So all of this is about working in partnership. No one organisation can do this alone. We all know that. So it requires bringing together patients, the NHS, business, charities, a whole wide range of different organisations. And that's always difficult to bring lots of different parties together. But it's also incredibly exciting, and new stuff will come out of that. And so I think that's almost embracing the excitement of it, whilst knowing there are obviously going to be challenges and things to work through from different organisations coming together on that. This is part of a lot of the activities from here being funded through the industrial strategy. And I know there are many colleagues, several colleagues here today from who've been involved very closely in supporting us through this. So I think it's important to kind of remember the message around actually how this is being used by a range of different organisations, from industry, from NHS, from academia, but it's really the whole collection of benefits that can come out of this. When we first started doing the work, we engaged with a wide range of people. Many of you have probably seen this slide before, reaching out to really understand what's going to be useful, what do people actually want, and that kind of message of let's really focus on what the user's needing rather than designing what we've already got together and hoping it all cobbles together on that. So we've engaged widely of a wide range of different people. And then the conclusions from that came out that there were a number of things that were needed, needing the kind of access to longitudinal, event-based, multimodal data sets, people needing better access to the data, needing scale, needing the speed of access, needing kind of expertise associated with that, and needing to use it for multiple purposes. These are still true. This is what people are needing, and these are the challenges we're having to work together on. And all of this needs to be, as Angela said, underpinned by people's confidence and trust in how this is being used. And Angela's chair of our wonderful public advisory board, who have been helping, guiding us and through the thinking throughout the entire process. And this has been, and what's been wonderful is actually other communities bringing together their public advisory boards and their different communities of patient and public to this as well. It's been wonderful collaboration on that. And this chart will be very familiar to people as well, as the different components of how what came out of that kind of that process of discussion and debate. And so we've got the Alliance, the hubs, the gateway, and the kind of feedback of the benefits from the users through to patients. So the public and patient benefit is very clear on there. And what I'm going to go into now is actually dive into each of those components. But before doing that, going into each of those, and the first thing I want to start on was actually the sprint exemplars. This was the very start of the journey. So many of you, if anyone can put their hands up of who's part of a sprint. Good, so we've got a good number from sprints represented. And so the different, you can see here the breadth of different areas on here. So this is what got a start of understanding, so not just listening to what people needed, but actually what if we just start getting going, put in a small amount of investment in and see what we can actually learn from the different types of things that come out of that. So we learned huge amounts from that. We learned about different areas around people who are doing things in what we're now calling better care space, around innovations and how that would work to get data embedded into care settings. We learned about actually what will take to build the gateway, what sorts of developments and advances needed in that space. We learned about actually what it would take for hubs to come together, bringing communities from industry, from academia, from the NHS together, how that works. We also learned about what it takes to do things at pace, and actually how exciting that is for people, and that doing things actually relatively, I know you might not be thinking that always, but actually the movement of moving through, a huge amount was achieved from those, which was incredibly fantastic to be able to see across that. So each of these has completed the work from there and producing reports, and so that's all been brought together, and the use cases from those will be made accessible to everyone. But they're also, very importantly, feeding into the next stage of the journey, which takes me on to the Alliance. So who is a member of the Alliance in here? Great, lots of representatives from there. So we actually have 27 Alliance members. As Andrew mentioned, it started a year ago. And we've got, as you can see in the tiny little charts there, a real mix of different organisations who are part of that. And there are 5 working subgroups, which is what we're going to be spending a lot of today on. So we'll be working through those working sessions so you can actually dive into the details of it. so including on data quality standards, and already convening. There's about 30 data officers from across the country coming together at regular points on this. The PPP, i.e. Development, so bringing the practitioner in there as well, knowing that really important relationship between the clinician and the patient as being really key in there. The Supporting Innovation Gateway. So as Jerry will take you through, we've got more than 400 data sets now discoverable through Alliance members on the Gateway, which is a phenomenal achievement. Also the promoting participation and improving access. This is about how organisations engage with the kind of commercial aspects of it, and this kind of aspect of being really important about doing this in the open, doing this publicly. So we had an event on this last week, which was live streamed, and any of you who wish to spend 8 hours of your life watching it, it's all available on YouTube for everyone to have a look on that. And there have already been 300 people who have had that time to look at it. And then of course the trusted research environment. So how we create a kind of the environments where the data is secure and trusted, and going to the safes that Angela took us through earlier. And this is a little clip on there of Dido Harding, who was at the event on the 22nd, and which you can have a look at, and she had a fantastic speech on there. Which takes me then onto the hubs. So who's a member of a hub? Lots of members of hubs. Look at that on there. It's fantastic. So 7 wonderful hubs, all covering a wide range of different things. The next chart is a little busy, but it talks you through the numbers and the people who've been involved, things that are going on there. So 100% of the 7 hubs met milestone 1. So pretty impressive, given it was done on the 31st of, exactly. And those who really enjoyed the 31st of December deadline, I am sorry for that. It involved involving over 100 organisations across these different sectors, 22 locations across England, Northern Ireland, Scotland and Wales. So a real national endeavour. 6 disease areas have been prioritised, so you can see the different areas, and they're really interesting areas and aspects in that, and you'll see that coming through on the Gateway side as well. I've put up in the kind of the top right-hand side here, I think this starts to get a signal of the sort of impact that's starting to come out. It came from when Ben and I have been going around having conversations with each of the hubs. And what started to come out was these extraordinary kind of global partnerships that were starting to take place. So, for example, when we were with Discover Now last week, just mentioning that with the AstraZeneca partner and an AstraZeneca partner mentioning this was one of the biggest global initiatives going on outside the US. I was like, that's interesting. Gut Reaction then mentioning, yes, the thing we're doing with Microsoft is seen as one of the biggest interesting things that's going on in Microsoft in terms of that. Okay, that's pretty interesting. Insight, then Alistair mentioning that he was going over to a conference with Roche, and that they were one of the top 5 things on the Roche Global presentation things going through. Okay, that's pretty interesting. And then, of course, those who've seen the NHS Digi trials, the announcement with Novartis on clinical trials on that. Again, national news and things on there. So it's really interesting to see what's starting to, you can draw different conclusions from that. One conclusion I might be drawing from that is actually people are looking, people are really interested in what's going on here. What you're doing is really mattering to people, and people are seeing this as exciting. So just see this as a start, but actually what could come out of this is I think, some seeds of interesting stuff there. On the bottom hand side then is on the bottom right hand side we've got the quality of data sets. So one of the challenges for each of the hubs for milestone 1 was to make data sets available, metadata available, and we've got a kind of assessment of the kind of level of maturity. And I just wanted to highlight that 4 of the hubs achieved the level 4 maturity, the kind of full technical submission. That was a really big achievement, and I know a number of people worked incredibly hard to do that. So a huge thank you particularly to DataCan, Discover Now, Insight and Gut Reaction for the work you did. And those of you who want to look on the Gateway, you'll see the depth of data that people have developed on that is phenomenal. Which takes me on to the Gateway. And the Gateway, then, more aspects and things on here. So we've got the minimum viable product, which is showing through the data sets that you can now make discoverable. So any one of you now, and hopefully, who in the room has been on to the Gateway? Great, and those of you who haven't, you need to go on the Gateway. We can already see you will be contributing to the 1,500 searches that have been happening. You can see there. You will also be what we can do now is you'll see on there are live dashboards that Jerry and Shashil have put together in terms of on the starting to see what's coming through in terms of the what the searches are. So over time, these at the moment are more people doing kind of demonstrator searches, so I wouldn't read too much into them. But it's actually, over time, we'll be able to see what people are looking for and why they're looking for those things. So it starts becoming a really useful information resource for everyone. There's already been over 1,000 people using it. And what we're now going on to the next stage, which kind of got in that the bottom left-hand corner, is going into the next stage. So this is just a very kind of initial search discovery type of tool. We're now going into the next stage of actually showing the going to technology partnership, and Jerry will take you through more details on that. And there's a number of people involved in that at the moment. And I will finish here, which is, I think, hopefully the message coming through from this. There's a lot happening, and each of us are doing our part and things in there. But what we can do collectively is enormous, and it is incredibly exciting. And people are looking, and people are watching, and people are starting to feel excited about this. So I think thank you very much for all your contributions so far. Today's going to be an exciting day, and we'll go into much more depth on the things that I've just skimmed over there briefly. And at this point, I shall hand over to Jerry, who will take you into the gateway.
So thank you, Caroline. Before I'm going in, I'd actually like to reiterate a little bit of what Caroline said. It really has been an amazing journey over the last 18 months. It's only 18 months. What has been achieved by all of the organisations in the room has been absolutely amazing, the pace and everything else, and the community that's building. So it's been great working with you. So we have a gateway. I saw those hands go up, so let's try that one again. How many people have actually gone onto the gateway? How many people have done that in the last 2 minutes since Caroline encouraged it? So it's good. So we started with a soft launch of the gateway back only a couple of weeks ago on the 16th of January. That was just to get it out there and get some testing and trials and see that everything worked, and it's clear that that made it out into this community really well. And since then, we've been building on that. We've run an extra sprint. We've added in some capabilities. So I'm going to go through a demo. This is the get the techie out the front and wait for it to all fall apart in a heap moment. So we're going to do it live. Okay, so first thing, it works. You will notice we've actually made some changes based on feedback. We've moved the search so that there's now a search on the landing page. Searching through live, we can see the details, and we've now added links through to the metadata catalogs. For those data sets where we have full technical metadata, and again, brilliant job to those who've already got there, that's outstanding. We can get down into the metadata catalog and look at the depth of information available. I'm not going to log in and make an inquiry because you're all sitting in this room, and if I start firing off inquiries for data access, I'm just going to fill up the system. But you can log on and make an inquiry across to the responsible data controller. One of the other things we've added, because it was really important to us right from the start, that it's great having the data sets on there, but we want the insight into how those data sets are being used. Bless you. So one of the things we've added in very recently is a dashboard. This is one of those moments that we see whether everything's holding together. So this gives us a view. So you saw Caroline's static view of the initial activity. This is a live view of how many searches have occurred, the total number of users, total number of sessions. So this is live data, and also gives us a view of the interesting search terms and a word cloud on what people are going for, which is quite a spread. I know it's people kicking the tires mostly at the moment, but it gives a view and a perspective on what's going on. We will be adding other things. We are interested in feedback about what data is interesting on the dashboard. And that goes back to a transparency. This dashboard is public. We're not hiding how people are searching. We're not hiding how many users are on there. We want transparency about how our data in the UK is being used for research and innovation. One of the things we're not yet showing, and a little test for the audience, is where those users are coming from. So it's probably easy to predict the first and second countries. Any guesses? Not from HDR Central. Any guesses on what our third most popular country is? Anybody want to shadow a guess out there? Finland. Right, okay. So the Finns are really interested in what we are doing with health data in the UK. So, as I said, we started off with the MVP in January, and that was a fast-moving effort to go from nowhere to having a working minimum viable product in a couple of months with, as Caroline highlighted, 414 represented data sets. But we've moved on from that. One of the important things is source code for this is now available. And that's really important because one of the guiding principles for everything we've been doing is do this in the open, build community. So we want to build the MVP, its future evolution, and the tools we build around this as part of an open community that can develop momentum, not just from the work we do directly. We provided institutional log-on. As I said, we've got the dashboards up and running. We're also continuing to work, and we really need you to help us get that feedback around making the user experience the very best it possibly can be. We've got a few things that we want to look at around in the backlog that we didn't get to for today, and so it will continue to evolve. We want to be able to store the search histories and people see what's being searched, not just on the terms, but actually to see the specific searches. There's further improvements we want to do around usability, and we want to provide those options of social login, not just through institutional logins. At the heart of this, though, is the metadata. So again, great thank you for everybody. Going into this, yes, we had some objectives of where we wanted the metadata to be by the time we launched. But I think most of us were, 300. 400 is a real stretch. We're beyond the 400. We're at 414. Some of it with deep technical metadata, some of it with breadth. So thank you for an amazing contribution to getting us to this point with the metadata. We have concentrated on breadth to this point, got some great depth too, but we will be continuing to evolve the work around the metadata being led by David's work, and that will be to go deeper for many of the data sets that today aren't at that sort of level 4 maturity, to continue to evolve the specification around what we see as good metadata. That's getting some momentum behind it, and I think that in itself is a really useful outcome of the work that's been done. And obviously, we shouldn't stop at 414. Where there are great data sets out there that should be available for research and innovation, we want to get them represented on the gateway. So in parallel to the MVP, and we are going to continue to evolve the MVP over the coming weeks and months, so we're going to continue to keep the momentum there. We are in the next stage of looking at what we do with the Innovation Gateway and building out a long-term technology partnership. So we're in the procurement process at the moment. We are in a particularly exciting phase, probably even more exciting actually for the 3 suppliers who are in the what gets cutely called a bake-off, the rapid development task. So we are down to the last 3 runners in the race. They are now in an agile and open contest to over 8 weeks to build out a little bit of what would be in phase 2, so that we can see what's the best fit for our community to build out the best possible tool we can have. We'll work through that. We will do a selection by March, and our aim is to be in live development for April. And that is to build out. We've started the journey, but doing discovery over metadata is important. It actually brings real benefit. We've already seen real Access requests go in based on what's already there in the MVP, but there's so much more we need to do to build out the end-to-end research and innovation journey. We need great user experience. We need to be able to do discovery not just over metadata, but we need to be able to do deep semantic search. We need to look at how we evolve alongside the trusted research environments in the UK. That's a wider topic that we'll be touching on elsewhere today. Build out libraries of tools, analytics, and supporting the human phenome work. Importantly, also access request management. We can make that a better experience and underpin this with insight. So we want to know how data is being used, what data gaps do we have, what people are searching for, what outcomes get driven off that data. So we want to build out this end-to-end user journey. And we want to build that out. We want to build that out with you. It's critical that this is a community effort. The Gateway isn't a HDR UK tool. It's in some ways a UK Health Data Research Alliance tool, but I actually see it actually as a tool that makes the UK the very best place in the world for us to do health data research. So it needs to be a community effort. So my closing request is, if you've not used the Gateway, go and have a go. If you have used it, go back, because we've changed it, we've improved it, there's new features, there'll be new features. And be a critical friend. Tell us what you like, tell us what we need to improve, tell us what needs to be added, because that's the way we will succeed with the mission of making this the very, very best place in the world to do health data and to support those benefits to our public and patients. So thank you, and hope you have a great rest of the day.
Thank you, Jerry. Can I welcome up David Seymour, who's our Partnership Director at Health Data Research UK, Jane Ingham, who's the CEO of HKRipp, and also Yvonne Silvo, who's the Associate Director of HKRipp. So thank you very much.
Thank you. I'll just do a very brief introduction. As Caroline outlined earlier, the Alliance is made up now of 27 different members. They cover national bodies, NHS trusts, research cohorts, and medical research charities. And it's been an absolute privilege over the last sort of year, pretty much, to see that group coming together, to see the new members coming on board, and to see the amount of energy and excitement there is to be involved in this. And so, because we sort of aspire to be an alliance that shapes best practice, but also to be an open and inclusive alliance, it felt appropriate to actually have one of the alliance members to actually give their perspective on that journey as well. So Healthcare Quality Improvement Partnership, or HKRipp for short, joined in July 2019 as part of the sort of the second wave. And whilst the original interest, I guess, from a HDR UK perspective was very much around the cardiovascular data sets, linked to NICOR and others to support the British Heart Foundation Cardiovascular Centre. I think what you'll find is the data that HKRipp have sort of the ability to make available goes far beyond that remit, and obviously a fantastic sort of opportunity to broaden that out further. So they've also shown great willingness to be involved in the programme so far. So it's an absolute pleasure to introduce Jane Ingham and Yvonne Silvo to provide the HKRipp perspective on the Alliance journey so far.
Great. Worked. Excellent. Good morning. And thank you very much for the Alliance for inviting us here today. I'm going to start off with a really generic introduction to HKRipp, because I have no assumptions that you've ever heard of us or know what we do. But then my colleague Yvonne's going to really take you into the specifics. So we were established in 2008, and we're very modern. We have three parents. We have the Academy of Medical Royal Colleges, the Royal College of Nursing, and National Voices. And we were very much set up as a patient partnership, and very much we're all about measuring and improving healthcare services. So it may not initially seem obvious why we're part of the Alliance, but hopefully this will become clear. This is a very old and well-used quote, but I'm using it today to really stress the importance of clinically relevant, patient-focused data. that aims to support teams in delivering high quality care. So maybe not the longer research, but teams to support them in addressing areas for improvement in the here and now. So how do we actually do this? What's our role in this? Our main work stream is the commissioning, management and development of the National Clinical Audit and Patient Outcomes Programme. And we do this on behalf of NHS England and the Welsh Government. And as you can see, the main methods we use are national comparative audit, confidential inquiry, and registries. So thank you very much for the plug for the National Diabetes Audit. That's one we commission on behalf of NHS England. And as you can see, we have around 30 national audits, around 6 ongoing confidential inquiries. We try and do some generic support work to help people use the data more, and we host the National Joint Registry, which I think now has 3 million records in it. So it's often used, adaged in the NHS, that we're data rich and very much information poor. And I'm sure that's right. But conversely, if you aren't measuring it, you won't know where you are and you won't know where you need to improve. So yes, we collect lots of data through the programmes that we commission. We weigh the cow quite a lot, but we do strive to ensure that the data is really turned into information that supports the delivery of high quality care. So one of the ways that we do this is through making sure that the visualisations of the data and the presentation of the data is really supportive. And this was an initiative that we undertook jointly with the audit providers and CQC. And it was really trying to say, what are the absolute key metrics within your audit that you'd want CQC to focus on? If they walked into your ward, your care area, what were the key things from your perspective that would say whether it's good care or not? We've mapped that to the CQC key lines of questioning. People have their data, the most recent data of what their performance is like. It's then compared to a national aggregate. It also includes a national standard where one exists. And then you can see from the coloured charts on the right-hand side where people are either above average, below average, or in the norm. And this result from this one, whilst it is Manchester Royal Infirmary and it's dementia, this result is really common in all trusts. Just about everywhere, people will have things to celebrate because they're doing really well. People will have things that they really need to improve on. And this really helps, I think, clinical teams know where to focus their attention, and also helps boards and trust boards with their QA role about what's going on. So that's our programme as it currently stands. And we have, as you've seen, lots of data sets that we're now making available. But what does the future really hold for a programme such as the National Clinical Audit and Patient Outcomes Programme? So from a data perspective, currently we use a mixture of around 72% routine data. So that's data that's already collected as part of clinical care. The rest of it is actually hand collected usually by clinical teams or audit teams out there. So that's a big burden for people. As I understand it, this is the national vision for what patient data flows will be like. Some of the timings might not be right because I think we all know that paperless 2020's been and gone. And some of the groups might not be quite right. And you'll all have spotted my deliberate error when I've said that NHSE was set up in 2019. That should say NHSX, sorry. But I think the vision is still, the intent, the vision is still the same, as in patient data, wherever care is given, will be collected. And at some point it will flow to a central resource, whatever that might be. And then that would allow people such as ourselves and other people that are interested in quality improvement to pull that data down. So they won't be involved, as Andrew was saying, in that 80% of data collection, data cleaning. They can get the data and focus straight away on improvement. So the data is... this is transition at the moment, so I think one of our focuses at the moment is really to try and make sure that the richness of the data sets that we currently have is protected and maintained through this transition period. So whilst the NCPOP data is not centrally hosted, it has a whole range of providers. We do share the data and we share it widely. We're really keen on making sure that data is being, whilst all the effort's gone into collecting it once, it's used multiple times. So over the last 8 years, we've reviewed 589 applications for data. It's about 70 per year, and these come through a real variety of mixture of people who want to improve clinical care, service evaluation, and then, of course, longer-term research. And that's really the message I'd like to leave you with is when you're considering data, think QI and service evaluation for clinical teams and trusts who want to actually make change in the here and now, as well as for research. To date, it's been a delight being part of the Alliance, but we have had to learn a whole new language. And I'm going to hand over to Yvonne, who's going to tell you a bit about the specifics of that. Thank you very much.
Brilliant. Thank you very much, Jane, and thank you for inviting us to speak. So yes, I get the fun bit, which is the reflection on our journey so far, and telling you a little bit about what we've been up to. I'm going to use the reading glasses so I can see this, but you are all a wonderful blur, so probably just as well. So yeah, HKRipp joined in July. We were officially announced as an Alliance member in August, and really work for us, and from my perspective, on being the kind of doer of the team for HKR UK, it started really in September. And I'm going to talk you through my reflections on that journey in the last 5 or 6 months. So as Jane mentioned, our first task really was to understand the language of HKR UK and what they were trying to describe they were doing. And I remember sitting down with David at the beginning with some of those key diagrams, poring over, trying to really understand what they meant and thinking, how does it fit with what we know in HKRipp, what we believe as an organisation, what we have planned for the future? What are they really trying to do? What's the approach? And will we work well together? And you kind of iterate that like a spiral, don't you? We discussed, we did a bit, we shared, we listened, we understood, we reevaluated, and round we went again. And actually, it's been a very positive experience in the last 5 or 6 months. We find HKR UK to be thoughtful, respectful partners on our journey, pragmatic, thank goodness, integrative. Timelines are certainly ambitious, and sometimes you hit bottlenecks, so it can go very intensely and then suddenly there'll be a bit of a gap and you wonder, and then it'll go intensely again. But I think that's the nature of a big beast trying to do a lot of things with a lot of different organisations at the same time. So our first task was metadata onboarding, and we were straight back to the dictionary again. What exactly do you mean by metadata? Exactly. It's not a term we use very much in our world. And onboarding, okay, that's also a new term for us. So we had to think and got our head around it and understood much more about how metadata was being used as a term. And for onboarding, yeah, for me, it was a boat. We were trying to gather things, we were trying to get them on board. So what exactly did we need to get on board? Well, we needed to define a data set. So that was really the first thing we had to do. What does a data set definition look like from HKRipp's perspective, which have quite a niche and kind of particular collection of data sets that we commission. And then we needed to decide what that first level of data would be, what we were going to catch in the net. So we went out there, we cast the net, we found 82 data sets. We were so proud of ourselves. And we got that first minimum viable set of data in for the MVP. We had a look together at the net, fish around in there, chucked out a few starfish that probably shouldn't really have been there in the first place, and sorted out the odd fish that was counted twice. But that was all good, and up we went on time, very pleased. We've also managed to get the next set of the deep dive metadata for 2 of our data sets in the National Joint Registry, and we developed a work plan together thinking about how will we work with all the provider organisations that we commission to deliver our programmes, how are we going to work together with them to help them understand about metadata and onboarding and the bigger picture of HKR UK, and to work together with us and integrate our vision and our delivery. So actually, metadata onboarding, once we've got our head around it, isn't that different to the sort of thing we were already trying to do. So from our perspective, it really does build on the work and our direction of travel. So in 2018, we developed something called UpCare, which is understanding practice in clinical audits and registries. And it's a tool for, in a structured way, describing every aspect about a national audit or registry, from what it's trying to do to the information it'll collect, and then how it's going to be linked or whatever, anything else that needs to happen to the audiences, and to the measures and to the types of outputs. So actually, we didn't know, because we weren't using the term, but we were already into the ballpark of structured metadata. So what's lovely for us is we can now work with the Alliance and work with the developing metadata descriptions that are coming through the Alliance and bring UpCare together with that, so that we all become part of the same language, part of the same description. Win-win for HKRipp and for the HDR community. And then in late autumn, the data officers group formed. So I had great fun pulling this slide together for you. We're in the dog house, if you want to say. So it was a bit of a challenge for HKRipp. So we're a commissioning organisation. We don't hold clinical data. So as you can imagine, we don't have a data officer or anything like that. But actually, this is a wonderful time to be joining such a group because we have got now the translation and the language going, and we will be able to contribute from what we do know and what we are experts in and gain also from the data officers. And we will then be able to trickle down our learning into all the organisations that collect data for us, who of course have that sort of capability, but not maybe as consistently as they might. And again, this work builds on our existing activities. So we already commissioned a requirement about transparency, about getting the data sets and all the supporting information we have out there on our project website so that people can find out about the data sets, what they're for and how they're structured. But there's huge variation about how and where the information is presented because we didn't really commission that with a particular uniform structure. So now the Innovation Gateway is going to help with discoverability, and the work of the dogs will improve the quality and consistency of the information that we provide. And then looking to the future, that's been a really fun part of the Alliance. Being part of the Alliance is a very forward-looking organisation that wants to look to the future right from the now has been very rewarding for us. Looking at things now has challenges, getting it right for the future even more so. So I would question whether our current view is the very best way at looking at things for the future, and clearly not for this young lad. HKRipp commissions linearly, so we take data from healthcare organisations and from other data providers and use it for quality assurance and improvement, as Jane was saying, and then we pass it on and encourage the secondary purposes from that. Others are doing the same thing, and the net burden and duplication is high because actually it's often easier for customers to commission a new primary data flow because they get so frustrated with how difficult it is to access data on a secondary basis. And all our IG approvals, and I don't think we're unusual, all the funding, all the resourcing, it all focuses around the primary objectives of each project. And the secondary use of the data is really an unfunded add-on. So maybe this linear model is getting a little bit outdated. In the future, high-quality digital data should and will be the natural byproduct of clinical encounters. And the future demand, even the current demand, is that the data is used interchangeably for healthcare assurance, improvement, research, service evaluation, innovation, payment and billing, all of that. So whilst HDR UK's initiatives are certainly going to enable better data sharing at that primary, secondary uses interface, maybe we should be challenging ourselves to establish data programmes with greater breadth of primary intent from the outset. And maybe this could have a bigger long-term effect. Perhaps that's one future direction in which we could train our spyglass. Thank you.
Great. Thank you very much. Thank you to David and Jane and Yvonne. That's fantastic. We're now going to go into the looking with Ben, and who's the Digital Innovation Hub Programme Director, HKR UK, and Liz Sapey, who's the Director of Pioneer, the Health Data Research Hub for Acute Care. And they're going to tell us a bit about the hubs. So do you want me to click through?
Yeah, thank you. Thanks very much. Thanks everyone for coming. It's great to see a lot of familiar faces. So yeah, thanks for everything you've done contributing to all the great stuff we've heard about earlier today. So everyone else so far has done a sort of show of hands, you know, who's looked on the gateway, who's part of a hub. So I'm going to do one that I think might have some quite low uptake. Who watched the Super Bowl on Sunday? Ah, got a few. That's actually more than I thought. So the reason I was just coming in at the end, just before I spoke, was because I'd just been alerted to the fact that my image hadn't loaded on the slides. So we're going to do a bit of imagination here. So I'd wanted to do a sporting metaphor, and but as an Irishman, it probably wouldn't have been tactful to use a rugby-based one recently. So I didn't mention the rugby. So instead, what we're going to do is talk a little bit about American football and we can take a journey through imagination land, because the picture that was here captured what I was talking about absolutely perfectly. So in American football, the way it works, you have a running back or a quarterback who gets the ball and runs it over the opposition's line to score a touchdown. But in order for that to happen, they have a whole host of teammates around them, guards and other positions that block the other team from tackling them. And this was a picture of a running back running over the touchdown line with the guards blocking people. And so working in this sort of infrastructure space, so in data curation, improving data quality, making it findable, accessible, interoperable, reusable, it can sometimes feel like the work of the guards. You're blocking the problems, you're holding people back, you're creating the space and doing a lot of hard work. Then someone else runs over the touchdown and gets the attention, with some great research using the data. So I think what we're hearing today is that shift in the narrative, the idea that actually the stuff that the guards are doing, the infrastructure work, that's the exciting bit. That's the bit that's getting the national profile, the global profile, and all the incredible achievements that have been made over the past few months have really contributed to that. So I'm going to coin or suggest a new phrase. We've talked a lot about infrastructure as service, an idea of supporting other activities, but actually I'm thinking of having stayed up late. One of the advantages of having a restless toddler is you get to catch sporting events at inhospitable times. So the idea came to me of infrastructure as a quarterback, because that's what this is. That's what we're talking about, being something that is exciting, that's ambitious, and that is capturing people's imagination. And so, this one did load. Fantastic. So the work that the hubs have done, although Andrew called it a showstopper, I think this was the show starter. 3 months of intense sprinting to get to the first milestone brought some incredible data sets that are now discoverable through the gateway. So some rich information, and as we were hearing already, queries and questions and inquiries about using that data for research are already coming through. And as Angela mentioned, the work across the patient and public engagement and involvement has been something that hubs have been doing, not just since they went live on the 1st of October, but actually for many of them, for all the months of contributing to and developing their plans, and even for years and decades before that. These organizations are bringing huge amounts of information, and the hubs are really collecting together energy that's going into talking to people and really having these rich, deep conversations about what this means and the exciting potential of health data. And so on the subject of quarterbacks and stars, I'm going to invite one of our thanks, good. We didn't practice this one. Yes, I'm going to invite one of our quarterbacks to the stage. This is Liz Sippy, Director of the Pioneer Health Data Research Hub for Acute Care.
So nobody throw me a ball, because I will drop it. I'm sorry about that. So thank you very much. It's a real pleasure to be here representing all of the hubs and the work that we're all contributing to. Our healthcare sector is too often very siloed, and the reason I wanted to get involved in a hub as a healthcare professional, as a medical consultant working at the front door of the hospital in the emergency department, is I could see the really negative impact that was having, both on the patient's care we were delivering today, but also for the potential we have to revolutionise patient care in the future. So these are real challenges that we face now. For patients and healthcare professionals, there's a lack of clarity on the journey that patients have been on. Their living experience of having a disease is often understood just through that one snippet that you see as a healthcare professional at one time. And that contributes to diagnostic delay and is reinforced in areas where there is poor digital maturity, which can highlight health inequalities. And the very people that we need to help change this sector have also sometimes struggled to get their hands on the tools they need, the data, to really innovate this sector. And even when they have got hold of the data, sometimes the quality hasn't been as good as we would hope it to be. So there's been a huge amount of work that's needed to make that data usable. So the hubs were tasked with trying to improve this. We set down really difficult challenges, and challenges that I think we're rising to across the hubs. First of all, to make it clear what data is available now. And going onto the gateway, it's incredible. Who knew that there were so many great data sets available now to use? But also to generate new data sets, to curate them within the hubs to really improve their quality so they have a better link directly down to patient care and innovation of patient care. To try and provide some national governance implemented with equity, whether you're a researcher asking for data, an SME or a large pharma company. And for those requests and for how we use data to be strongly directed by the patient and public partners that are included in the hub and outside of the hub. And we think this offers a huge benefit, a huge opportunity, this national framework to ensure that we get the very best out of the data we've been collecting for years in silos and siphoning that back so that our patients feel that benefit, the UK population feels it, and hopefully the global population benefits as well. We have aims within the Pioneer Hub as well, the acute care hub, and that is to generate a completely new data set that hasn't been available before. So we're trying to curate and link on an individual basis data from primary care, out of hours primary care, the ambulance services, secondary care and community care. Starting with when somebody's suddenly unwell and looking at that data both before to understand the pathway and journey, but also outcomes as well. And in Pioneer, we're not looking at a particular disease. All comers welcome. We don't mind if you've broken your leg or you've had a bad episode of diabetes or a rare disease. And we're also including children in this journey as well, so their data is being curated. And what we're hoping to do is identify and test those points of change where we could do things better now by actually understanding our data now, which we don't do at the moment. And then thinking about the new ways that this data could be used to really change our sector. And I'm really proud that patients have been the heart of our processes, not just within Pioneer, but across the hubs. We're hoping, my figure didn't work as well, it's not just you, Ben. We're hoping to take what we learned from the West Midlands region and apply it nationally, so there's benefits from all. So as we've set out on this race, the get ready, go, what we've learned, I've tried to capture in a couple of slides. And the first is that when you talk to patients and public members about health data, they are incredibly generous and altruistic in how their data is used. We've had some very open and honest conversations about the kind of uses we see for their data. They're really interested in this process and they absolutely want this to work. But this is something that we, within this sector, must never take for granted. There is an awful lot to do, and time is incredibly pressing. And that's why it's going to take a collaborative effort in order to align our data and make it really useful for innovation. That includes public, the patients, clinical teams, also computer sciences, information governance teams, the R&D systems within hospitals, universities, and policymakers. And we want to involve those policymakers as well, so that the insights that we generate can be applied across our populations. What I've also personally learned is how keen NHS bodies have been to share their data. And that's something perhaps I didn't appreciate before. But what we have to do is recognise that there are differences in digital maturity, which means people can join data sharing agreements maybe at a smaller scale, maybe at a slower pace, and we have to account for that, and we have to facilitate that. It's much easier to gather data if you can draw down a very clear steer about how it's going to help the patients that NHS Trust is trying to look after. And the important thing about making it inclusive is it does give us an opportunity to reduce some of the national health inequalities that are present and hopefully some of the global health inequalities that are present. We have to do it in the most transparent way possible. We have to have very open conversations about how people can access data, the criteria we're using to grant license for access to the data. And I think if we can generate some test cases about how this has benefited patients, and all of the hubs can do that, we can all now give you working examples of data that's been provided and things that have changed for patients because of that, perhaps on a small scale now, but with huge potential on a grand scale. These conversations will get easier and easier to have. And I do believe these benefits are real and they will be important for our population. And I've got 3 slides really to outline why it's important. So this is a true journey of a patient heading towards a diagnosis of myeloma, a blood cancer. Actually, they had it from the very start when they first went to their GP. But you can see the number of individual healthcare contacts they've had over a process of 8 years before that diagnosis was made. If we'd have linked those journeys, if we'd have understood the pathway better, we could have made a diagnosis early and perhaps have prevented some of the negative effects. There is also an opportunity to hopefully improve how our data is used when we're prescribing drugs for patients. This is already a hot topic in cancer therapies, where we know some patients benefit more or less from different dosing schedules. But we could apply this across our population so we could understand which patients are most likely to benefit, have side effects, and which patients the medications might harm. And again, through large data sets, we have an opportunity to drill into that in a way we've never had before. And also we can use the amazing tools around us from some of our device and medtech companies to innovate this sector. For me, that means hopefully not waves of people coming in through the emergency department as they are at the moment, because perhaps we could provide care in a more appropriate setting of the patient's choice at an earlier time, so they don't come to us in a rather collapsed state. So our next steps, well, I have the words of Professor Morris ringing in my ears: more and better. We're on it. We need to keep reinforcing the huge potential for benefit. There will be lots of people that may be slightly concerned or have reservations about this journey we're going on, but the overwhelming possibility for patient benefit should be our North Star, and we should be heading for that all the time. Transparency can only help us, but we also have to learn from each other. All of the hubs are going on a new journey here. We're all trying to make as much use of the expertise we have across the hubs, so that we can not only learn from each other, but learn from our mistakes, which we should own. And we should also learn from the different patient voices and public voices that we have embedded across the hubs, because they will help guide all of us. And I think we have an opportunity to make our patients extremely proud of what their data has and will achieve for the UK and beyond. Thank you.
Thanks very much, Liz. So what comes next? So we talked about the 31st of December as the deadline for the first month. Oh, the deadline for... Sorry, someone's got a clicker somewhere in the audience, just trolling me. So the 30... I mean, I was joking, but I think that might be what's happening. It's all right. I can talk without slides. I've done it. That's how I started anyway. So our new deadline is for milestone 2 is the 31st of March, a much more social date. And this involves a number of different elements. So milestone 1 was about establishing, it's about setting up, putting the teams, the physical space in place, putting in plans for patient and public engagement throughout the lifetime of the hub, and making data sets discoverable. So now over this, and that was very much, as we've heard the word sprint several times today, that was about getting things off the ground and up and running. And now, so with a bit of a longer timeline ahead, there's looking at use cases. So what are the activities that the hub is supporting and making possible through the work that you're doing? So now that the data is discoverable, what's the work to be done on increasing the utility, so increasing quality and scale, and adding more data sets in and opportunities to link those data sets, and then continuing to work on the patient and public engagement and involvement. One of the useful pieces of feedback from our public advisory board during the development of the hub competition was about making sure that every single one of the milestones looked at patient and public engagement and involvement. So it's a continuous process rather than something that's set up at the start and not being evaluated and developed. So we've got quite an exciting year ahead of us, lots of work to be done. I expect the word sprint will continue to feature heavily in people's vocabulary because there's just so much energy that we're discovering across the community, and by bringing people together through the hubs and through the other work that's taking place, the things that are happening are on a much bigger scale than had they been taking place independently. So together, what can be achieved is exciting and inspiring. So I think now, speaking of together, I'll be inviting our speakers from this session onto the panel. Yep. So please join me.
Thank you very much, Reid. So there's a bit of a changeover of chairing of this piece, partly because I want to have Caroline on the panel as well. So you'll have seen that the question for this section in particular is around how we involve and engage patients, public and practitioners or staff working in the NHS within this programme. And I guess one of the key themes that's clearly running all the way through today is around trust. And that involvement and engagement is obviously a necessary but not sufficient piece of the jigsaw. But I think you'd all appreciate it's really important. And going back to the first Alliance board meeting, one of the points that was raised very early on was about that involvement of NHS staff, whether that's frontline clinicians, whether that's admin and clerical staff working in sort of back office type functions. They're a really vital role in this process of making sure that they both act as advocates for what we're aiming to do with the data, but also actually appreciate the real importance of capturing high quality data at the point of input. So that's why that sort of practitioner or that NHS staff piece is in the mix as well. So we're going to open up for questions. I appreciate that you've all been sat on sort of listening mode so far, so hopefully you've got a number of sort of pent-up questions. The focus is obviously on the patient, public and sort of NHS staff engagement. But if you do have sort of burning question about any of the other aspects that you've heard about in the programme that you feel you really want to ask now, because that will otherwise sort of smooth the way for the rest of the day, then please feel free to do that. We should have 2 roving microphones. So what we'll aim to do is to take 2 questions at a time, which allows the panel a little bit of time to think about the first one before they jump in. So hands up for who wants to go first. Yep. I'm sorry, if you could just obviously say who you are, roughly, and where you're from, or what your community is involved
with. Okay, I'm Monica Jones. I'm Chief Data Officer of DataCan. So we've talked quite a lot about data and the use of it and in improving it. Not wanting to put a damper on anything, but we have a system where patients, the public, can actually opt out of their data being used for secondary purposes. I'm not sure whether it is true or not, but anecdotally I've heard that actually the biggest group of people who are opting out at the moment are actually NHS staff. What do we think that we can do as HDR UK to actually inform them more so that actually we get that sort of trust? I think that, rather than, and bring them with us, because once we turn that around, then actually they can be our greatest advocates. But at the moment, I think we're potentially we've got some sort of, information issues there.
Okay, great question number 1. Gentleman.
Sven Bunn, Programme Director for Barts Life Sciences. My question is very closely related to that, so hopefully that's a little bit helpful. But I was wondering about the extent to which you're thinking about concepts of dynamic consent, so that there's not just a sort of one-off opt-in, opt-out, but there's the opportunity for people to think about consent for specific uses and the sort of opportunities to say yes now, no later, and and actually through that to help improve the sort of dialogue and feedback to individual patients about how their data is being used and the benefits from doing that?
Okay, thank you very much indeed. So we've got opt-outs, particularly around NHS staff, and then the dynamic consent. Any?
Hi, if I might, I don't know if my mic is on. Can you hear me? Yes. If I might take the NHS staff being one. So the way that Pioneer has gone about this, before we thought about Pioneer actually, and afterwards, is we've held a series of events around the hospital talking about health data, because we recognise as you said, if we could somehow foster the NHS as our workforce spreading the good news, it would make all of our lives much easier. And again, there's been some misconceptions that we've just had to work through. But actually, with just a very simple leaflet, which we've published, which I made with the help of Kevin, who's here, who helped from the HDR UK Midlands site, we've been handing those out to staff members, and the feedback has been incredible. So you're right, this is a workforce we have to engage with. It will take some time and some targeted work, but the opportunities there are huge if we can just all grab them. And the way that the hubs are distributed with members across the breadth of the country means there's a big opportunity for that in a hub and spoke type manner.
Jane or Yvonne, sorry, I've got Angela as well. Have you got anything from the sort of HKRipp perspective on?
Yeah, sure.
Sorry, yeah,
can you hear me? Yeah.
You might need to lean a little bit closer to it.
Can you hear me now? Yeah. Okay. I think I'd second that. I think that there is a real opportunity to make the visibility to people while they're travelling through our healthcare services, understand how their journey will impact not only themselves but others in the future through their data. And I think perhaps there's an opportunity to look at more times along the journey where those conversations can happen. So, for example, if you come into hospital now and having broken your hip, your data is being collected about your journey through to treating that hip, but it's also being used by the same teams who are treating you to understand whether their treatment is starting to slide to excellent or slide down to areas of concern. Now, I don't know how much the patients are involved with that communication about that knowledge, and I think there's it's siloed. The clinical teams know it and use it, and they treat the patient, but the two shall meet. So I think there are lots of opportunities. The one thing that we have done historically in the programme is that we've tried to use the data to inform patients directly. So again, through things like hip fracture database and others, you can get a leaflet that says the data from the National Audit tells us that you should have a scan in a certain period of time, go to theatre in a certain period of time, you should be expecting to leave hospital after a certain number of days. So it turns around the data into information that is directly useful for a patient during their journey.
And they can then see that data, that's now publicly accessible on the website as well. So that, again, I think when people can see how it's being used and have the confidence that it's used for that, improving their journey, it will hopefully help.
I think locally that does happen. I've worked on an acute trust for the last few years, or before I took hospital, but I think it's that sort of when it goes outside of your particular sort of trust, it's that, it's that sort of, what are they doing with it? Are you selling it to the Russians? And that was actually a direct quote that we got back in Yorkshire and Humber when we did a public consultation exercise, was that they were happy about sharing the data for direct care and actually even for population health management, but please don't sell it to the Russians and don't give it to those people down south, which obviously we've got to work on.
Angela, you want to?
Yeah, I hadn't heard that about NHS staff using the national data opt-out. As I understand it, the proportion of people actually using the opt-out is actually still very, very low. But I wonder whether all the talk about GDPR, particularly among staff, and the kind of fear that's been engendered has actually put them off. And one of the problems with the national data opt-out is it's a blanket opt-out, and it's the opposite of dynamic consent. And I really would like to see more experimentation with dynamic consent. I personally think that actually the patients should be seen as the custodians of their own data, but we're probably a long way from that. But at least if we could engage people in thinking through what they're happy about, their data being used for and what they're not, that would, I think, do a huge amount to help educate the public. I recently sat on a panel assessing Horizon 2020 projects from the patient's perspective, and there were a number of proposals to set up systems of dynamic consent to try and engage people in these kinds of discussions and thinking it through. I think that would be really positive if we can do that.
So related to that is one of the long-term ambitions we have for the Gateway is to be able to provide a very clear perspective of how data is being used to generate outcomes, not outcomes in the abstract, not outcomes in here's a set of academic papers, but in terms of lay summaries of changes in treatment pathways. And one of the key things is about that transparency, but also having ambition. I know it's an ambition we share with NHSX, to eventually for that to be a personalised journey so that you as a patient can see the studies that you participated in and what changes and outcomes that drives. Because then I think that changes the conversation, changes the narrative from a narrative around who have we sold the data to those in the South to a here's my data, it's actually changing things for the world. And I think that it's not an easy one to solve, don't get me wrong, but I think we should be ambitious about how we view transparency and how we make that a personalised experience long term.
Thank you. Any more perspectives on the dynamic consent piece? But also, I guess, out in the audience, if people have got, is it a point about dynamic consent, Kathy, or is it a question? I find either way, but just check.
Well, it's kind of on the same topic on this primary secondary use thing. So I just wondered if the panel could reflect or comment on the use of the terms primary and secondary use, where the margins are often blurred and where the term secondary use often suggests something a bit more minor or a bit less important than primary use, whereas actually if we started to think of research that's for patient benefit as being a primary use case, we might kind of improve the perception of the way in which the longer term uses of data can really sort of come back to help patient care at the coalface. And I think Jerry's points are very apposite from that perspective. But the use of the terminology could be very important here. I wonder what people think of that.
Thank you. I'll pick up one more question, certainly one in the middle, please.
Hi, Monica Fletcher from Breathe. I think I'm putting a plug in for my cafe this afternoon because I think there's been a lot of concentration about the financial viability of the hubs particularly and what models we might use. But this whole thing about value is so important. And I think we're sort of, the reason why I'm running this afternoon is try to capture on your behalf, but on everyone's behalf, what are we struggling with here? How do we actually demonstrate value? What tools might there be out there? Should we be looking at social impact tools? You know, what is it? How do we measure this? Because running them almost separately isn't helpful to us. So, and this is what patients want. This is what the public want. I mean, I was in my car yesterday and I heard the discussion around Cambridge Analytica on Radio 5 Live, as you do. I don't know if anybody else heard it. And it was all terribly negative. And this guy from the north rang up and he said, anyone can have my data for nothing, he said. He said, it's not worth nout, is what he said. And then this whole discussion ensued about how important his data was. And there was the example about the diabetes database, et cetera, and how that's changing care. So I think we've got a lot of work to do. If anyone wants to come to my session with any ideas, but if we even generate a whole list of the things that we're thinking about, it would be really helpful, I think, to feedback and to learn collaboratively here. So thank you.
Thank you very much indeed. So I guess the question on that one for the panel as well is then about that measuring and communicating value. So we've got the terms primary, secondary use and the term and the language, and then the value question. Ben.
So I think just touching on the primary and secondary use, I think you're absolutely right, Kathy, and I think it links to Monica's question about the engagement of staff. So having come from the NHS before, there's a lot of talk about the burden of data collection, and there is a danger and a risk that an increased focus on health data becomes actually more troublesome and more burdensome for frontline staff, because ultimately they're the individuals who are collecting the data that we've been talking about. So the way I would say around that, or to counter that, is about that push on what we're actually doing with it and what's happening with it. So absolutely, I don't see this as secondary use insofar as the outputs of this work will change behaviours, change treatments, and have a real impact on the front line. So it's how we can collectively share that good news and push that story as a way of actually demonstrating what's happening. And I think the idea of it being something secondary is very much contributing to that.
Other perspectives from the panel on this one?
Yeah, I think so. Just kind of adding to that and bringing those two, I guess, points from Monica and Kathy together. I think part of this is what you're saying almost represents some of the challenge of what we have about bringing these different communities together, where language of secondary and primary and different aspects kind of almost highlight the differences we have between different areas. As we're going into this, we're going to have to work through that, obviously with the kind of legal aspects and all the things well thought through on that. But we're going to have to think through how do we actually connect things up and tell stories. I think the point that Yvonne made earlier on about the language being so different between us in different environments and what primary means to someone. One person means primary care, another one means primary use. Just the language we use is so interpreted differently by us. I think that's why us all coming together and working together and connecting together and starting to think through what does a patient see as being really impactful and valuable in here. Whereas a scientist of working in everything might see this as being really impactful, but if when talking to a patient, they might not really connect and understand that. So we have to be bringing these communities together. Today is a start, but it's a long way to go so that we get to language and ways of talking about things that really do make a difference to each of us and to members of the public and patients whose data is being used on this. So it's not really answering it, but it's just saying this is a start and we have to go a lot further.
And I'd like to add to what Monica has brought up already, is that the concept of value means so many different things to so many different people, but for the patients that are in front of us, it means improving their care there and now, and also hopefully preventing anybody else from undergoing the same experiences that they have. So value isn't just monetary, and we're all well aware of that, and it's how you can expand that picture of value to make sure it means something to every NHS patient and trust that we're working with, because that's how we'll get the broadest buy-in, and that's how we'll get bigger and better data sets to provide even more value and help for our population.
Thanks.
I agree with that broadly, but actually I think there is also quite a big sort of upswell of altruism. I mean, when you ask patients why they get involved in research studies, it's not just to improve their own care, it's also to help people like them in the future. So I think we can build on that.
Thanks. Just pick up on the point about value to NHS trusts. So I guess the question is to how we sort of demonstrate that the work that they're involved in increasing numbers within the Alliance and how that really benefits them. Are there any sort of perspectives on that?
So from the pioneer perspective, what we're doing is for our data providers, our data partners, we're helping them understand their own data so it can be utilised for their own reporting structures and their own patient populations, so they can see direct benefit from data coming into us, because we're taking sometimes the onerous burden of then trying to create their own data in a way that enables them to meet their targets and to improve their own care processes. So that's the buy-in that we've used, and I think that's why it's been one of the easiest conversations I've had, because they can see the benefit of being part of this, not just in terms of the wider structure and the grand vision that we all have, but actually on a practical day-to-day basis.
And I think if I just add to that, so in addition to effectively the kind of more immediate benefits from there, there's also the concept that as an organisation involved in research, having your clinicians as being active researchers who are looking at data and questioning what they're doing, improving care and things like that, we all know that does deliver better outcomes for patients, and the more we can have this embedded in as a culture and a way of working, is going to make better care for all of us.
Back out to the audience, there's a couple of questions or points over this side, please.
Hello there. Anthony Tutor, I'm the lay co-applicant at the Breathe Hub, and the word I've not heard mentioned, which I feel would reassure members of the public, is pseudonymisation. So where data must be identifiable, are we talking to them about pseudonymisation? Are we pseudonymising their data and reassuring them that identifiable data isn't actually going to be out there for researchers, but pseudonymised data would be?
Thank you. And second one.
Matthias Fucik from Imperial College. I would like to ask about data entry. So as a bioinformatician, I work a lot with the data. And often I think one crucial point is the manual data entry. So I can imagine if this is rolled out for the NHS staff, which is often overworked, the data entry needs to be facilitated, and it needs to be ensured that it's complete and also correct, because otherwise we have got all this missing data or falsely labeled data in the system, which is difficult to get out. So what systems can be implemented to ensure good and high quality data entry?
Thank you. So question around the anonymisation to identifiable information spectrum, and then one separately around get it right first time on data entry. Angela, so I think Angela pick up first, then Jerry.
I think first of all we need a better word than pseudonymisation. It's hard to pronounce, impossible to spell, and nobody understands it, or at least very few. We have to find a better way. I mean, previously I've looked at whether people even understand anonymise or understand the difference between anonymisation and confidentiality, and on the whole a lot of people don't. It's very confusing to people, so we have to find, it's yet another example where we have to find a really good way of explaining this.
Yeah. Jerry, do you want to?
So there's obviously a prize running, I think, for Angela's here, so who can come up with a better word? I do think the words matter, because I do think this confuses people. The data that's being worked with under the guidance of yourselves and the other data custodians is de-identified, pseudonymized, where that's the appropriate thing. But that in itself is not sufficient. So I'm going to do a plug here, because we've got a session later on the trusted research environments. The conversation I think we need to be having is a two-layered conversation. It is a conversation around the data and around different approaches to de-identification, but it's also a conversation around what environments, what projects, what people. It's the 5 safes that were discussed earlier around providing that as the wrapper around the data, because the one is insufficient without the other, because approaches to pseudonymization, to de-identification are imperfect. It's only the wrapper around it that gives us that approach to research and innovation that allows us, I think, to have a narrative in a way that we have to have in lay terms with the public. So definitely I would encourage you to come along to the discussion on the TREs that Tim at the other end of your row of chairs is going to be running a bit later on, because that's a really important conversation to be having.
Okay, great. And then on the data entry one, colleagues from HKRipp at the end, do you want to start on this? Because clearly that's important for the audit side of the things, and you've been doing, I'm sure, doing work on this already.
So we do focus quite strongly on this, obviously. So a lot of it is around the engagement with staff and what the aims and the objectives are of the project, so that they've got that passion about working and supporting with it. Design of capture tools that don't allow you to put rubbish data in, so you get rubbish data out, and increasing use of routine data that's already being checked and done elsewhere. That gives what actually goes in better quality, but it doesn't necessarily give you completeness. And that's another aspect that we're trying to look at, is to make sure that you've actually got complete case ascertainment, as well as individual cases have high quality data.
And I think I agree, and to add to that, we're human beings, so we're driven by what is useful to us. If data entry isn't inherently useful to us, what's useful is what comes back out. So I think trying to make sure that what is coming out is really user designed, is like a chair that people want to sit in, not a chair that we think they want to sit in. So as much as we can, that's where HKRipp's really focusing, is what do we give back immediately when they enter data? What is immediately useful in the daily work of these teams? And that's on one half, and the other half of our whole world is this is totally not sustainable. This can't go on much longer. The NHS can't have a lot of these individual high quality data collections, but the only solution is that point of capture when you're with a patient, it has to be designed for that breadth, not the primary, secondary, but back to that breadth of uses with a meaning and a transparency that means something to me as a clinician as well. As I'm entering it, I understand where and how I'm going to benefit from this data, how my patients will benefit, where it's going, and what ends up happening to it.
Thank you. Caroline, did you have a...
Yeah, this is such a big deal, and this is effectively where and I couldn't agree more strongly in terms of what I'm saying, that the point of if we talk about curation, improvement, and data quality, post hoc curation is really expensive. The further away you are from the point of actually where the data was collected, that's time consuming, and it's not as good as if you get it at the point of data entry. But I don't think we should underestimate in terms, and I'm sure we're not, but the variety across the UK in what the challenge of, even if you get to the point where the clinician is entering the data or the different individuals are entering the data, how challenging sometimes if you're on a ward, they've got one computer on wheels that they're sharing between many different clinicians, and it's perhaps not as reliable, it's slow working. It's really hard to enter the data sometimes. So I think some of the how the NHS is making those investments in this really challenging financial environment is clearly really key. One of the things we're doing through on the Better Care programme, which I know some of you might be aware of, is actually how we're starting to kind of embed these aspects improvements within NHS settings, and how we can actually get closer and closer to the point at which the clinicians are working on that. So I think this is again, the start of a very interesting journey, I think, on that.
Excellent. So a big thank you for your questions, but also please a big thank you for the panel and their responses. Hopefully you'll agree there's a good set of topics to take into coffee and other refreshments, which you've got for the next 20 minutes. So you can be making your way back to your seats at 11:50. We're moving really from getting that sort of shared understanding, shared language session into more sort of detailed work stream areas, and your sort of contribution and engagement in those is obviously key. So enjoy the coffee and comfort breaks, and we'll be back in 20 minutes.
Okay, so lots of interesting themes coming out of the conversations this morning. So clearly a theme around working together and learning together. And by doing things together, we can achieve a lot. Also a theme around diversity of skills and expertise and how we're bringing that together, how we build common language so we can actually really work effectively together. Themes around transparency, public benefit, how are we actually communicating that and really making sure we're focused on the value and impact for people. And also that message that this is just the start. So there's a lot more to come. And so on that note, we're going to go into the cross-cutting work streams, which is a snappily titled aspect around the work that we're doing across the different parts of the Alliance. So if you remember back to the charts on some of the earlier ones in the Alliance, there were 5 cross-cutting areas. What we're going to have is presentations from each of them, just 5 minutes, very quick, snappy presentations that almost get you your appetites whetted. So we actually go into the working sessions that are going to happen straight afterwards. So we're going to have 5 minutes of presentations from each of the areas, followed by a 45-minute working session. You have to go and I'll point to you. So we'll pause and at the end of the presentations, and I'll direct you once you've had a chance to see which ones you're interested in and want to go and join. So first of all, I'd like to invite Amanda White to come up and join us to talk about earning, building and sustaining public trust.
Thank you, Caroline. Morning, everybody. Afternoon. So this cross-cutting work stream has a title that's a bit of a mouthful. It's Patient, Public and Practitioner Engagements and Involvement, so PPPIE. So we're trying to simplify things here. So I think this workshop is about how do we earn and build and sustain public trust. It's a theme that's been coming across through this morning's discussions. So the aim for the workshop is to agree some practical next steps and to discuss some methodologies that can take this conversation forward. We've been discussing here, but we've also been discussing at previous workshops and events. For example, the events that we ran with CASME and the Academy of Medical Sciences last week, where it's clearly understood that this area of work is hugely important to achieving our mission. And so how is it that we're going to work together? Caroline's mentioned that this is a common theme as well that's coming out this morning, to share the ideas and best practice that we have within the hubs, within the alliance organisations and the other partners that we're working with, to really move this forward. So what we would like to do is to explore some different examples for this in our workshop. So what we're looking for at the end of our 45 minutes, it's not that long, but we thought that having some examples of ways that our organisations are already earning public and patient trust. We heard from Liz earlier with some examples, and there's lots of other ways that we're hearing about through the hub. So it would be useful for us to really share those ideas, and perhaps at the end of the session have some concrete examples that we can communicate and we can share with one another. We're also looking for some suggestions for how to reach seldom heard groups. There's a recognition that's coming out in some of the hub plans for public engagements that there are various challenges in reaching out to different groups and really involving the people that we need to. So some suggestions for how we might take that forward would be really useful. And then also some examples of your existing resources, tools and methodologies. So does deliberative engagements work to help answer some of the questions around the grey areas that we've got? Are there other tools that we can use, and how do we be really innovative in our approach? So that's what we'd like to achieve. I've got Katie from Discover Now. If Katie's here, give a wave. And I've got, thank you, Katie, and Sindhuja, who will be helping with this workshop. So please do come and give your ideas and opinions. Thank you.
Thank you, Amanda. So a fantastic pitch there, but there's more to come. So you don't commit yourselves yet. Joanne Hackett, who's Chief Commercial Officer at Genomics England, is going to talk to you about commercial sustainability. Welcome, Joanne.
So no whizzy presentation because this is exciting enough as it is. So how about that? No, I don't have a presentation because effectively I want to be able to have an open conversation with you. I think many of us understand that the word commercial is sometimes viewed as a very scary and terrifying word to many people. It shouldn't be. I think we need to think about what scares us and how to break down those barriers. For the most part, most of the technology today for data sharing, federation, and various things like that exists, but we're not actually using it effectively. So what should we be doing to be able to break down what's scaring us, to be able to make sure that people can access data? I often say that we get a bit confused sometimes when we think about the commercial aspect of it. Let's think of it more as data accessibility for the right reasons. So we're going to speak a little bit about some of the stuff that has been working, that we've been working on behind the scenes. There's a commercial framework that we've been putting together. This is not a signed, sealed, and delivered document. So we'll discuss that a little bit today as well. So your input into that would be great. I'll have David. David, you're in the back. Do you want to wave? Helping in the session today. We've been working on some stuff together over the past couple of months, so we would welcome your input into that. So I will leave it at that. Great. See you soon.
Thank you, Joanne. And there's more. So ethics and governance. We've got Clark Crawford from the Ethics and IC lead at one of our hubs, Insight. So I'll just get you up there. Thank you very much.
Thank you very much. Good afternoon, everybody. So my name's Clark Crawford. I'm Head of Research Governance at University Hospitals Birmingham, and I'm supporting two of our hubs, that's Insight and Pioneer, from that angle. So our journey has kind of been simplified because we've been adopting pre-existing frameworks, specifically the HRA, which is the Health Research Authority, our regulators' guidance on research databases. So we're using this as kind of a vehicle both for our ethical review, but also for allowing us to think about and create the structures that we can work from to make sure that the hubs are delivering on everything that they need to deliver on. So I'm assuming no prior knowledge here. So for those of you that aren't familiar with the research database review and term, these are voluntary things which allow research databases to grant favourable ethical opinion on the projects that they support, that they provide data to. So this very much speaks to the way that we want to be working with our gateways, etc. So there are 400 of these in the UK, so it's a fairly well-established framework. And I appreciate that some of the hubs actually might be in this 400, but interestingly enough, I can't actually tell. So what we're going to be doing is really sort of looking to mirror the way that the biobanks are working, taking best practice from them, making sure that we've got common standards like interoperability, the way that we'd interact with Gateway, and other things that I'm sure you'll all recognise from that. When it comes to the legal aspect, we've been bringing together trust and university partners on these two hubs with their respective internal authorities. So we've got obviously the directors, got patient groups, data protection officers, IG leads, so on and so on and so on. So we worked really early on to try and identify and have absolute clarity on what legal entities are involved, what their responsibilities are, and who internally is either executing those responsibilities or is overseeing and approving those kinds of things, so that we have absolute clarity in the way that we're building both of these hubs in a way that all organisations know they can deliver on them. So what I'm really interested in my workshop is trying to get representation from each of the other hubs to see exactly how they're doing it. I realise that our model is not the only way forward, and we'd like to sort of explore what other mechanisms people have put in place for them. And at the end of the day, we're all going to be hopefully recognising a common approach, or at least abiding to common principles. Okay, thank you very much.
Brilliant. Thank you, Clark. And then our next one then is two people coming up. So we're going to be going on to data quality and standards, so much of what we touched on this morning. So Neil and Monica could come up and join us.
Thank you very much. So I'm just going to speak briefly about data standards and quality, so I do need to try and make it sound exciting. This has come up various ways this morning. So if we go back to the data that Caroline originally showed here, improving the data is a key thing. And one of the things around improving the data is around how we can make the data more interoperable, how we can try and reduce that 80% that Andrew mentioned earlier that is having to be done with each study. And this whole concept here is what we are going to be discussing. So this group has already kind of started off around the establishing a data officers group across the Alliance. I'm massively grateful to everyone who's been involved in that, with the intention that we looked at a very high level paper around standards to agree moving towards open standards. And the next step really is to really go down this list in thinking about how we represent our data, what kind of models we use, how do we make that more interoperable, how are we all using terminologies, etc. But this is going to become more and more important as we move on and we start thinking more about all of the different types of data sets that are going to become available through all of us, both through the hubs and through all of the Alliance members. And there's a big opportunity for HDR UK to really work on this particular element. But the workshop itself is going to be really addressing some of these themes, which are the standards? So we all agree that we should be moving towards open standards. Can we start to coalesce around some of the particular standards? How do we actually evaluate how good a data set is? Because what's good for one person may be different for another. And the question is, can we start to come up with what would be an agreed measure of data set utility, and around what are these things in the word of curation that we always use? What are the bits of that that we should be doing? And we're going to actually use an example from the DataCan hub around a maturity assessment. I'm afraid your slide is not here, but will be printed out for the workshop. So Monica's just going to tell you very briefly about the maturity model.
Right, well, therefore I can keep my powder dry. The anticipation, if you want to see this maturity matrix, you've got to come to our presentation. So yeah, as Neil said, the data officers group, fondly known as the dog, and I did like Yvonne's picture this morning. We formed a subgroup around sort of data quality, which I'm leaving. I don't know whether that makes me the deputy dog or where we sort of like go from here. But really, so within DataCan, what we've tried to do is come up with the good, the bad and the ugly in terms of what we think is sort of the maturity of data sets, and some, we hope some easy to use kind of metrics that actually says where you are sort of on that spectrum, that we can work together, we can hook it into national sort of data quality assurance sort of frameworks, and that we can also hopefully collate and signpost and syndicate people towards tools that will actually get us on the path to improving data quality, which we've all signed up to do. So really that's all I wanted to say at the moment.
Fantastic. And on to our fifth area, which we have, now let's see if trusted research environments with Tim Hubbard. Yeah.
Thank you. So you've got this gateway, so you can discover what data there is. The data's all been cleaned up and nicely standardized. The remaining question is, how do you actually access this as a user in a way that's trustable? So this is, we've heard about the 5 safes. So the question is really, how do you implement the 5 safes? So the central sort of maybe slightly constraining question here is to implement something where you don't distribute the data anymore. You have an environment where the data stays, people bring their analysis to that data, and all the processing happens inside that environment. So that's how things have been done in social sciences for quite a long time with small data sets. It hasn't necessarily been the way that things have been done for large data sets, but there are multiple examples of systems operating in that way now with very large data sets, such as Genomics England, but also, the whole of the Swansea Empire has operated in this way for much longer, but with smaller data sets. So the public's highly sensitized to this question of data. Of course, we can have research cohorts, but if you want to go to whole health systems, this is an opportunity to, in many ways, reset this conversation. And if you say in focus groups, as we have, various stages, we're not actually going to, the data's actually not going to move. It's not going to go to any of these companies. It's going to stay where it is. People feel much more comfortable. So this is, the existing way is, to some extent, some groups have been doing distribution. I think the point from the public point of view is you've lost control as data custodian. You can't really put your hand on your heart and say, I know where it is. And you can't automatically guarantee anonymity, even if it's been de-identified. And so there's an inherent lack of public trust. And genome data, particularly, you can't actually anonymize that anyway. There's nothing you can do to change that data. All you can do is de-identify. There are additional things, though, that now there's GDPR. So if you've got another copy of the data yourself, you're liable to GDPR. Suddenly it's become a liability rather than an asset. And when the data sets get very large, from a funding point of view, you're paying for multiple copies, indirectly or directly, and the network costs of distribution. So suddenly GDPR combined with the costs of distribution suddenly make it more attractive from funding agencies and management points of view to operate these sort of environments. If you operate the environment where you don't, where access is access only and you don't distribute, you get some benefits. You get the benefits of being a custodian, saying you can always know where the data is. Privacy doesn't depend on anonymization so much. You do that at what summary level data you allow to export. You save on distribution costs and duplication costs. And it's now technically feasible with virtualization and cloud computing kind of things to make this happen. And just to show how this maps onto what we've done in Genomics England, which is, of course, an example where there's 20 petabytes of data, you certainly don't want to distribute that. You have a cycle for the clinical side, shown in blue. It's a single data center which also hosts the trusted research environment to satisfy the researchers. And it implements these 5 safes. Safe data in the sense of de-identification of what's shown to researchers, safe projects, the open management of access review, but then safe setting is this environment where you have to bring your tools inside this environment and do your computing there. And this has been shown now to operate. There's 3,000 researchers who are signed up to using this environment. And because you've got that safe setting, means you can control what data has gone out, so you satisfy the safe outputs, and you can manage who's actually using that data, because if it's not being distributed, you know exactly who's been authorized to see it. There's extensions in the sense of if we're going to get into cloud computing, it's not just an on-prem system. We have to be confident that we're going to use cloud in a secure way. So there's some criteria around that are being proposed in the Green Paper. And then there's another extension. Once you've got this structure where everything is very close together, makes it easier to link between clinical care and research, because potentially you can maintain that link and send results back onto the clinical side. So that's it. So come to the session if you want to discuss what the technical problems are of doing this. What are the issues in terms of moving to this world where you only do your analysis in a single place.
Fantastic. Thank you, Tim. So this is where the work starts. We've got 5 groups. Each of them has kind of set out the fascinating topics. Unfortunately, you can't go to all 5, so you're going to have to choose at this point. If I can suggest that perhaps if you're here with different people from your organisation, maybe split across different ones so you get a kind of breadth of perspectives. And I think that the different groups will really welcome that. Okay, what we're going to do is we're going to do very quickly in the next 10 minutes so we can all have lunch. Each group's going to come up and play back up to 2 minutes of what the kind of key messages were from their discussion. I went around each of the groups and the conversations were fantastic. So I know there's a huge amount and it's a big ask to condense it down into a couple of minutes. But I'm going to open with Amanda.
Thanks, everyone. I'm going to carry on as people are walking into the room. Firstly, just to say thank you to everyone that came to our workshop. It was fantastic. There was loads of great ideas. I'm just going to summarise the key things that came out. We had a lot of representation from Alliance members, charities, hubs, and other organisations that we're working with. So it was a really good mix and a really rich conversation. I think what we all agreed was that we don't just want to do the same thing that's been done before with public engagement. We want to be quite innovative. We want to use different types of approaches for really reaching people. And the idea was to look at examples from organisations that are doing this really well, both within and external to the sector. We also talked about if we do public engagement really well to build public trust, how do we measure that public trust? And we struggled with that. So I think that's something we need to work hard as a community to really pin that down. But one of the examples was, let's have a look at an organisation that's really engaging with the public, like the blood donation service, and the type of data and feedback that members of the public get back from that service once they've donated blood. Other lessons were to be very proactive, so responding to some of the negative publicity around data stories and being on the front foot with that. And thinking about how we can create a network of networks so that we can really build on all the great expertise that we've got within our various organisations. So we're going to come up with some practical ways about how we can connect as a community. We talked about the roles of HDR UK being a convener, but also providing sort of that national oversight, but also then enabling all of your organisations to work together and really sort of build that momentum. There was a great idea that we should perhaps have a storyline in Coronation Street about patient data to reach the public. So that's something that we could work on. And we talked about how do we really get into the public with these stories, perhaps making better use of media partners that some of the bigger organisations in our network have got. So I think that covers it, unless I've missed anything. No? Okay. Thank you, everyone.
Thank you. And Joanne, David? You doing it, David? Yes. Lovely.
Thank you. Yes, we were doing commercial sustainability. I'll just preface briefly by saying that we focused the conversation around a framework that HDR UK published last week and took to the CASME AMS meeting last week, which involves a commercial framework which includes use-based payments, so fee for access, service charges, etc., and outcome-based payments, so share of cost savings or share of revenue further down the line. We have those two elements. So we discussed around that. It was thought that that was a good framework in the sense that it provided flexibility, the ability to blend different models, the ability to price differently for different use cases, which was important. But it was pointed out that we also need to take account of other ways of sharing value, for example, in-kind or partnership arrangements where industry might provide analysts, for example, and share both resource and learning, and that needs to be factored in as well. Again, focusing on the framework specifically, we discussed the outcome-based side of it, the fact that it creates risk and delay, and particular complexity if it involves taking equity in a company, and that needs to be taken into account. We had quite a long discussion about the need to raise awareness in industry of what the hubs and what other data providers can offer, the fact that today is quite undervalued by many partners, and the need to understand what uses industry and other potential users really have, and to make sure the offer is right for them. And that's could be quite a costly process, but an important process to understand. And the sense that the Centre for Excellence that NHSX is setting up might help with that. We touched on the need to gain support and trust from the public through public and patient involvement and engagement as a crucial basis for this. And then we approached the question of equity from a number of different directions. So there was discussion about the need to ensure that benefit to the system is shared across the system, not restricted to the institutions that are most in the forefront of doing this, but also to ensure the institutions that are involved each receive not only a share of the value, but also are involved in the governance and have a meaningful say in decision-making of that. And that's quite an important thing to think about the ecosystem. And to ensure clearly that pricing is fair and there's a fair return to the NHS. And lastly, we talked about learnings. So the ability, the willingness and the appetite to learn from other organisations that have already done this and to share learnings as an important part of the journey. So for us, a really useful conversation, which gave us a lot of important feedback as HDI UK. And I thought was really helpful. So thank you all for those who were involved.
Thank you. And Clark, to talk about IG and ethics.
Thank you. So I think our conversations, we've got some perspectives from multiple areas, different hubs. Largely, we recognise that there is a difference between our organisations and the way we're approaching this. And part of that is due to the way that we've been driving forward with either test cases or whether it's built on a historic, a pre-existing kind of collection or arrangement. So we all recognise that there were, I think there were some issues that we can address, and I think taking each other's perspectives on that would be quite useful. I think we're agreed that there is best practice in the sector through other mechanisms such as the research tissue banks, looking to work that's been going on in Scotland, and we really need to draw that in as we're considering the way that we build these things. And we're also, I think, looking to build a community of practice in this area. So people who didn't attend this workshop, we think if you've got a handle in this, or if you've got a steer that you want to provide, our recommendation is to get in touch with David Seymour, who will put you in a link, because I think it's as a community that we need to keep together to make sure that we're standardising as much as we can the way that the hubs work. Okay.
Thank you. And Monica and Ben on data quality standards.
Ben was writing and I can't read it.
To extend the sporting metaphor, Monica offloaded just before the line. So I think first thing on this is that, data quality and standards, getting to a shared national position on this is hard. There's a lot of work and thinking that's gone into this before, so it's not, what we don't want to do is sort of steamroller over huge amounts of time that's been invested in this already. The second point is that it is incredibly important, and now is the time for us, and now we have the opportunity to get this right. Making sure that it's always tied to specific uses and use cases. Something that came up repeatedly through our discussion was about one user or one person's needs being very different from the other, all the way from, public health, research, clinical audit, AI or algorithm development. Each of those will have different needs when it comes to data utility. So in terms of steps needed, so there was a clear agreement that actually seeing something written down, having a framework to talk to was incredibly useful. And so lots of thinking for us to do on some of the definitions, without getting overly philosophical, but what is data? What is a data set? What do we mean by curation? So having this as something that we can make visible to people, so not that we're all aiming for a certain sort of platinum level, 100% across every dimension, but actually just providing that information so someone looking at a data set can, along with knowing about the sort of summary metadata, so where it is, what coverage it is, the scale and size, also knowing what level of say completion or verification has gone into it. And then I think potentially the last point is that actually this is also really interesting. So the idea that data quality and standards is the boring one is something we strongly rejected. So this has a really interesting technical element to it, but there's also how we capture some of the human behaviors. So knowing that, say, a particular field in a data set has been completed differently by different people, and that as they're bringing their biases into data collection or own pre-existing ideas, how do we capture and display that to users? Interesting.
Lovely. And last but not least, we have trusted research and rights with both Jerry and Tim.
Yeah, he needs mind up.
So the model I outlined, there wasn't any great shouting it down.
No, not so.
But it's, it is for those who are used to distributing data. It's a cultural change, and it raises lots of questions in terms of how you technically implement that, particularly if you're a data custodian going from distribution to running an environment. Do you want to run an environment yourself? Do you want to outsource it to somebody like Swansea that's prepared to offer to host environments for people? And then lots of questions around how do you federate things together, because there's very little that's really been done so far. How do you bring software in? How do you bring other data in? So lots of technical details, but nothing show-stopping, I would say. And in terms of how we take this forward, there's a green paper which is evolving, which will get distributed to sort of interesting people to comment on. What else?
Yeah, there was probably two other conversations that came through, possibly three. We had quite a good discussion, bit of a debate around the role of public cloud. So that's again going to be a discussion. There was also a discussion that came up, and I'll note as an action, around analytics tools. Noting that we are going to put a tools repository as part of the gateway, but also whether as an alliance where we're working with commercial tools, there's an opportunity for us to bring to bear some bulk buying power here.
And license portability.
License portability around particularly a federated trusted research environment. So there might be some commercial questions to come out of it. And I think the other one was that there was general agreement, I felt, in the group. There's lots of things to be worked through around what this would look like, how we would audit and certify environments, what the architectures that possible might look like, how you manage safe outcomes. There's a lot of work to be done. So as Tim mentioned, there's a green paper, but actually we need active participation as well in the discussion so that we can really address some of these.
Okay.
Thank you very much. Lovely. So thank you. So I think as you've seen across these 5 different areas, each has got, as mentioned earlier on, I like the term knotty issues. Each has the knotty issues within them that we've each got parts of the threads to be able to unknot and to work on. So that concept of actually how we can bring the collective knowledge and wisdom together on this so we can actually unpick them and work through the solutions on that. Using frameworks is part of helping with that. So you'll see in a number of places, the quality framework things, that gets you into the topic. It starts to kind of make you think through actually practically how this can work. Using use cases is going to be absolutely essential in this as well. So these are just ways in which we can work together and bring something that we can all focus on and work together on. Sequencing is going to be important as well. So what we do first, what we do next, and how we break it down so it's not kind of overwhelming, but we can actually steadily work our way through. How we use things like the gateway and the alliance as means of coordinating and bringing us back together. So we're developing, making transparent things through common tools and purposes. And the final point, which Clark mentioned, which is around the leadership and the people getting involved and taking part in this. This is a fantastic opportunity for all of us to really develop, lead and take pieces on. So don't hesitate, get involved. There are opportunities, don't wait to be asked. This is a space crying out for people to get involved and take leadership activities in it. So hopefully it's whetted your appetite through the things you've heard, and also we'll be pulling together the outputs from each of those sessions so you can see what was covered in the other discussions as well. You now have 45 minutes for lunch, and we'll be back here at 2 o'clock for the World Cafe event, which will be particularly exciting. So if you think you've covered a lot today so far, we'll just wait to the next section. It's going to blow your minds. But have some lunch, meet with lots of other people, and look forward to a great session at 2 o'clock.
So hope you enjoyed your lunch. Hope you're feeling sort of energized, refreshed, and particularly, actually, I hope you got a chance to meet with and talk to various people that you might have flagged on your delegate list or from some of the presentations this morning. In many ways, a lot of the value of these sorts of events happens not just from the things that come from the front, but in the opportunities to connect with colleagues throughout the breaks. And hopefully then this World Cafe session is a chance to continue that. So what we have and what will be sort of happening in the room behind you, it's a sort of transformation as you come in, is that numbers will be added to each of the tables. So the way that each of these, or the way that this session works is that there are 18 tables, each with a kind of different theme or topic, and so various individuals or groups will be presenting their work or something that they're doing or working on, and you'll have a chance to join 4 of those through the afternoon. So what we're going to do at this point is have the various presenters give a 1-minute pitch on what their topic is. I've been nominated to kind of chair this and run that through because I am ruthless with a stopwatch. I'm a former classroom teacher, so people getting chalk at their head if they overrun. So I'm just what I'll do now is just invite anyone who's presenting or hosting a World Cafe table to stand in this open area. And I'll line up in single file. I'll just do a little bit of filler just to keep the crowd growing. Hear how you're all doing. Yeah, good. Anyone here from Scotland? From Belfast? Yeah, there we go. So what we'll have 15-minute rotations. So what we're going to do is actually ring the HDR UK gong after 14 minutes so that we can manage the transition. You should all have in your welcome pack a World Cafe table map. There's one person in the room who I know doesn't have one because it's this one and I stole it from a table at lunchtime. So there'll be a spare one at the front here. So there are, as I said, there are 19 tables. Makes your choice even harder than I originally specified. So colleagues behind me, I'm going to call you up in the order that you're in, and you'll have 1 minute to pitch to the lovely folk here. So I'm first going to invite Paul Jackson, Elizabeth Wayne from ADR UK. You have 60 seconds.
Good afternoon, everyone. Paul Jackson from Administrative Data Research UK. We are an investment, which is an infrastructure, which is trying to link together whole population data sets and then provide 5 safe access to those data for accredited researchers. Monica, forever known now as Deputy Dog, talked about how they are using a maturity model to better understand, to get a grip of what are the qualities of the data in HDR UK. we've been using a maturity model for the whole investment. We've come up with an idea about how we can measure qualitatively what good, better, best looks like for all the attributes of our investment, and we are measuring that each quarter, and we have a visual, one glance, and you'll understand where we started, where we are, and where we're going to in a easy to understand, chief executive will get it way. And if you want to have a go at that yourselves or see how it's done just for fun, please join Lizzie at table number 1.
Fabulous. Thank you very much, Paul. Adrian?
Good afternoon, everyone. So I'm Adrian Jonas. I'm the Associate Director for Data Analytics at NICE, so the nicest person holding a world table. We're a strategic partner of HDR UK, and we want to increase and extend the use of data in the development and evaluation of our guidance. So what we've done is we recently published a strategy or statement of intent which sets that out. It covers what data is available, when it could be considered, for instance, extending managed access to other topic areas beyond cancer, and some practical considerations. But this is all very high level, and we're now defining a programme to establish the methods and standards frameworks that will be needed to support our ambitions and the system in the coming future. So if you want to contribute your thoughts on anything from biasing sources of evidence to validation of analysis and communicating uncertainty, or Ben, even just the statistical best play to when you're 3rd and 9, but please come to my table. Thank you.
Great, thanks, Adrian. Macy?
Hello everyone, hope you had a good lunch. So I'm Macy Murray, I work at the MRC Clinical Trials Unit at UCL. We form part of the collaboration in the London site, and my table is about HDR terminology. Are we speaking the same language? And I've noticed this morning actually from our conversations that there is some confusion around language and terms that we use. I have quite a varied career in health research, starting out as a lab assistant, moving to trials, and then back to pharmacoepidemiology, where I use longitudinal health records before I moved back to trials at the MRC, CTU. And I now work with electronic health data in clinical trials. And I've noticed that there is sometimes confusion between disciplines, especially in the UK, but also even across countries, in how we talk about electronic health data, especially routinely collected data, and the terms that we use. So the aim of my table today is to aid communication across our different disciplines and research groups by asking you to help me identify other terms we frequently use for data and how we define them. Thank you.
Which, not making space for persons unknown. Number 4, fair partnership for accessing NHS data. Great.
Hello, I'm Grace. I'm from Understanding Patient Data. We're an independent initiative hosted here at Wellcome, for those of you that don't know us. And we aim to make the way that patient data is used more visible, understandable, and trustworthy. And we're just about to launch a new piece of research into what the public thinks makes a fair partnership to access health data, whether that's between the NHS and charities, industry, or academia. And we'll also be publishing our kind of policy recommendations off the back of that, to where we outline what we think needs to change. It's a super hot topic. Like, we've heard that already this morning, and there's loads of scare stories in the press about the dangers of big tech accessing NHS data and the kind of concern of the public. But we wanted to go out and actually find out what the public thinks of this as an issue. So in this session, I'll share some high-level findings, ask you to consider how they're relevant to your work, and feed that back to us through the discussion.
Great. Thanks very much. And Amanda and Stefan.
Hi, so I'm Amanda Evans from the Human Fertilization and Embryology Authority. So for those of you who don't know, that is the fertility regulator in the UK, and it has one of the largest databases going back to 1991 for fertility data. While we have this big database, we've only been able to give out data from it since 2010. And we've gone from having 1 or 2 research projects per year to having about 30 expressions of interest in the past year, while we've closed it down to update our process. So we'd love to hear how any of you deal with the whole process of giving out data, for approving data to be given out to researchers. And we can update you on what we've been doing. We'd love to hear about what your mistakes were when you were doing your own, and that sort of stuff. Thank you.
Thank you. And Arlene?
Hey, so hi, I'm Arlene. I work at the Clinical Practice Research Data Link, and I'd like to ask the question today, how do we evaluate the impact of using healthcare data to support safer prescribing? Fits a little bit within the better care thing, so if you're interested in that area. The CPRD, if you haven't heard of it before, we collect electronic healthcare records from primary care, which we make into a database that comes from general practices, and we use this for lots and lots of research projects. And in the last couple of years, we've wanted to try and give something back to the GP practices that provide data to us. So we've developed these sort of feedback reports that are useful for quality improvement within a practice, where we're focusing on patient safety in prescribing. So we've developed 7 indicators so far. An example would be prescribing of valproate in women of childbearing potential. That's one example of the many we have. And these reports are free and go to practices on a regular basis. So now we're at the stage where we'd like to see what the impact of that is. And so we're looking for ideas from anybody who can give us some suggestions as to how we might measure that, what the success might look like, what sort of analyses might we want to use. Thanks.
Thanks very much. And now Katie and Amir.
Hi, I'm Kate Glazer, the Collaborations Engagement Manager for the UK CRC Tissue Directory and Coordination Centre. We are an Alliance member and a contributor to the Innovation Gateway. We manage a tissue directory where researchers can search for tissue held at over 200 UK biobanks. And we also work with the biobanking and research community to try and maximise the use, impact and value of UK tissue. We will be talking about how we work with UK tissue banks and how that links to our work with Health Data Research UK. We want to ask you guys what you think we should be doing to make it easier to work with tissue banks, what you see the barriers as, and explore your expectations of how this could look in the future.
Thanks very much. Joanne?
Hi there, I'm Joanne Hartley from the Medicines Discovery Catapult. The Catapult is a not-for-profit organisation funded through Innovate UK, and we're there to try and help drive innovation within drug discovery. I work within samples and data access, so our main role really is to help researchers, mainly from industry, and within that, particularly from small to medium enterprises, find and access clinical samples or data sets to enable their research. As we've heard today, patients, the NHS, healthcare industry and the life sciences economy in the UK can all benefit from the ethical and trustworthy use of health data. And in the UK, there are 1,500 medicines discovery SMEs employing 21,000 people. As part of MDC's support of the drug discovery SME community, we conducted some research to understand health data needs and challenges of the life sciences industry. So the roundtable is to share the outputs of that, to hear your views on those challenges. And to particularly hear whether there are any particular challenges from a data custodian perspective when it comes to SME engagement.
Thanks very much.
Sorry.
Thank you. Caroline and Helen? Or Helen?
It's just Caroline, I'm afraid. So good afternoon. My name's Caroline Morton and I'm from the Data Lab at the University of Oxford. So I'm here with Ben Goldacre, who's just over there, and we'd like to invite you to join our table to discuss the issues in using open methods in healthcare research. So we're the team that's behind Open Prescribing, which is an open source project that we've to date have shared 44,000 lines of code, and it's got about 130,000 users, but it's not been without its difficulties. Working in the open, we've got lots of experience of this, and we'd like to share some of the barriers that we've come across, hear about your barriers, and then think of ways that we can make things better for everybody.
Thanks, Caroline. No, Deborah.
Hi, so I'm Debbie Wake. I wear 3 hats. I'm an NHS diabetologist, a clinical reader with the University of Edinburgh, but also co-founder of a digital health company called My Way Digital Health. And our main product's My Diabetes My Way, which is a self-management platform for people with diabetes. And I'm here with the remit of My Way Digital Health being one of the HKRipp sandbox exemplars. So my question is about, throughout my own journey, I've used data for audit, for research, but also for R&D in terms of new product development. And it's really about about how we can speed up that impact of innovation to produce products that might be used both commercially and non-commercially. So my question's really about how do we best make data available, both in a sort of timely and cost-effective way that's really going to speed up and encourage new product innovation. So join us if you're interested in that. Thanks.
Thanks very much, Debbie. Heather.
Hi, Heather Pinches from NHS Data Trials. So we're one of the hubs, and we're all about using routinely collected NHS data to support clinical trials. So we're seeking a range of benefits around improving the speed and efficiency of trials, but also looking at things like widening participation, both for individuals and for research sites. So the initial focus of the hub is the development of a feasibility service, which is about how we use data to identify where patients are that meet key eligibility criteria and help to support the planning and design of clinical trials. We've taken a user-focused approach, so we've done a range of user research and we'd like to share that with you. We'd like to also test with you our thinking around our service delivery roadmap, and we've also come across a number of wider challenges as part of this work. And again, we'd like to hoover up any ideas you might have about how we might tackle some of those wider challenges.
Thanks. Thank you. And Chris.
Thanks, Ben. Hi, my name is Chris Russell. I'm leading on the data creation strategy at Discover Now Hub. So it's lovely to be here and see you all. So what is Discover Now? It's a digital innovation hub. It's a real-world evidence platform. We have 2.5 million records that are integrated. So it has primary care, secondary care, mental health, community, high-cost drugs. There's quite a lot in there already. We're already up and running as a real-world evidence hub and also a feasibility service. But what we want to speak to you today about is like what are your main pain points around using real-world evidence? When is it difficult? And what can we do to develop our hub and our service to make our data better and your research more impactful in terms of industry and also for patients and healthcare out there as well? Please come and see us. We are at table 12. Thanks.
Yeah. Thanks, Chris. And Luke.
Hello, everyone. So I'm from Data Biology. We worked on one of the sprint projects, developing a prostate cancer research hub out of the Big Data Institute in Oxford. So what I'd like to start is a conversation based around an opinion we have at Data Biology, which is based around the idea that if you have an understanding of your data, be that genomic, be it metadata, longitudinal, you have an understanding of your applications, the tools you want to use, be that a custom script or a pipeline, and you have an understanding of the infrastructure, hybrid, cloud, HPC, you can start to drive clever automations where you can use that to improve researchers' lives and make it a bit easier. For example, doing things like providing application suggestions. If I have a cohort, here are 5 tools that you can use based on your data. You can use it with 50% of it, and these are the results you can derive. So come challenge or contribute to that conversation, please.
Thanks, Luke. And Charlie.
Hi there, I'm Charlie Davey. I'm Director for DataCan, which is the Cancer Hub. Many of you will know today is World Cancer Day, so I would argue there's a moral imperative to come to our stand and to learn about the second biggest killer, a disease that will affect 1 in 2 people in this room. So come and work with us. We want to work across the whole of the Alliance to see how, using our expertise and skills, we can really help impact on cancer care across the world. Thank you.
Thanks, Charlie. And Monica.
You get 30 seconds because I did a quick pitch this morning. So I'm the other Monica, and I'm just here to talk from the perspective of Breathe. We've been very much involved starting up with thinking about sustainability and thinking about the financial models. But what's sprung out of that is actually what is the value of what we're doing? And in a way, I think I want to turn that on its head from just thinking about the finance to look at what the value is. We need to think about who our beneficiaries are, who they are. And I think we could learn from social enterprises by looking at the social impact models. So if you're looking at what the value is, come and see what we're worth.
Great, thanks, Monica. Neil.
Hello, I'm Neil Walker. I'm IT lead at the NIHR Bioresource, a panel of 140,000-ish people with various diseases who could be recalled for experimental medicine studies. We are a Sprint, a Hub, and an Alliance member. I've changed my mind what I'm going to do a roundtable about, because I actually listened this morning, which is unusual. So the title is, should we use the public cloud for analysis of health data? And I would seem that people here believe we should, how on earth do we convince the public? Because that is the real challenge, and if no one trusts us, it's not going to fly. So that's what I'd like you to come to me, and I can tell you what we've been doing, and you can tell me whether it's wrong.
Thanks, Neil. So unfortunately, Vasa, who is hosting table 17, can't be here today. So I'll move us on to either David or Rodrigo. Or neither David nor Rodrigo.
I am neither David nor Rodrigo. My name's Laura Shishodia. I am standing in for Rodrigo today, who is ill, sadly. I work at Iridia as a product manager. We, for those of you who don't know, have created a digital research environment, which is made up of two components, our FAIR data services and secure workspaces, where you can use the data from the FAIR data services in a kind of secure audited environment to do your analysis. We worked with Great Ormond Street on the last sprint, where we've used the FHIR standards to create smart on FHIR apps to kind of show an example of how we can use the data more within the clinic setting, and also sharing that back with the patients as well, so they can see how their data is being used and actually what data the hospital holds about them. So you can come find me and possibly David in a bit on stand 18. Thank you.
Great. Thanks very much. And now Ash or Adam.
Hi, I'm Adam Millward, co-founder of Metadata Works, and we're on table 19, and we've been working with Parity and HDR UK on the onboarding process. I guess we're here today as much as anything to meet all of the hubs and alliance members who've been putting the submissions in, because it's nice to meet all of you in person and to say thank you. But I guess the three big things we'd like to discuss today are, do you think the metadata you've collected is useful? How hard is it to collect? And is there anything you think we can improve? So we're going to distribute some QR codes. So we've got a survey going around. We've got loads of chocolates. So if you fill in the survey, feel free to take some chocolates. And yeah, come and see us at table 19.
Getting a lot of hisses from this corner of the room. It wasn't against the rules. And last but not least, George.
Right, and how do you follow that? Okay, hi, I'm George. I'm one of the people responsible for training at HDR UK. And today, really, what I'm interested in is, out of the 5 safes, it's the safe people. And I'm asking the question, what are the skills and capabilities required of a user of health data? It's really important when we're earning public trust that we actually have transparency in the skills that our users have. So today what I'm going to ask is, what is the minimum that somebody needs to have in order to use the data? Where there are schemes already out there, accredited researcher schemes, for example, by the ONS that are used, but is that enough? Should we have a badge or belt scheme that increases in the number of skills and capabilities that somebody uses health data?
Great. Thanks very much, George. And before we do anything else, can we get a round of applause for everyone who's spoken? On the sort of on the data side of things, I've actually now got a great data set showing 19 different pitches and how the time to pitch decreased as the pitches went along, because people had more time to prepare and were aware that I would be leering over their shoulder if they overran. I enjoyed that too much. So as I said, we have 4 15-minute sessions. So I'm just going to pause while I'm standing here, just reflect over the 19 options available to you. They're all available in your handout. The way the table numbering works is that table 1 starts by the lifts, your right, my left, and carries on numbering up until table 20 is then on the other side. So my right, your left. Clockwise. Yeah, that's true. Good. So what I'll do now is, before any folks in the seats move, I'm going to ask my table hosts to make your way to your numbered table, just so they've got a bit of time to prepare, gather their sheets. I'll do a bit more filler. So it's not raining. That's good. Data, it's good stuff. So what I'm going to ask you to do now, the time is 2:24. We're 2 minutes ahead of schedule. Well done, everyone. So I'm now going to ask you to make your way to your first World Cafe table, where you'll have 15 minutes to talk before we ring the first gong. Go forth.
Okay. Okay, thank you very much indeed for coming back after coffee. Thanks also to the table hosts on the last event. I mean, certainly the three that I managed to get to were excellently put together, really useful, and some great conversations. And that seems to be the general feedback that I picked up from people over coffee as well. So I thought it was a fantastic range of ideas and sort of opportunities that were being discussed, as well as challenges. So lots to sort of reflect on and take forward in that piece. The final bit now is our closing address. I'm delighted to be able to welcome Jenny Tennyson, who's the Chief Exec of the Open Data Institute. As many of you may know, the Open Data Institute was established in 2012 by Tim Berners-Lee and Nigel Shadbolt to show the value and sort of, I guess, advocate for the use of open data and its benefit for public good. Jenny herself has a PhD in AI, joined the Open Data Institute as technical director in the formative days before becoming the chief exec in 2016. Jenny brings obviously a cross-section perspective and I think therefore is ideally placed to help talk to us about increasing access to data whilst retaining and building public trust. So please welcome Jenny.
Thank you very much, David. And I'm very aware that I'm between you and going home and having a rest for your brains, which I think are being very active through the day. So I won't linger, I promise. I'm going to talk about trustworthy access to data and yes, try and bring in some of the kind of lessons and learning that we've had through our involvement across a range of sectors and the way in which we think about trustworthy access. This has already been talked about. If you don't know ODI, we're a not-for-profit based just around the corner in Shoreditch with some illustrious founders. Our vision is that we want to have a world where data works for everyone, and we particularly focus on working with companies and governments to build an open and trustworthy data ecosystem, and I'm going to go into a bit of what that means as we go through the talk. What I thought I'd talk about today is kind of three things. First of all, just a bit of the way we think about the way data brings value to society and the kind of threats that there are around getting the maximum positive impact from data. I'm going to talk a bit about the importance of trust and how to retain it and talk through a couple of frameworks that we use in order to think through that and hope that that's useful for you guys as well. And then I'm going to talk a bit about kind of institutional models for managing trustworthy access to data and again, the kinds of things that we've been exploring and hopefully of some use to you here. So the way that we think about getting value from data is through this fairly simplistic type of value chain where we see we want to have a positive impact in the world, where the way that we have a positive impact in the world through data is by having people decide and act differently because of information and data. Those decision makers tend not to be the kind of person that goes into spreadsheets and analyzes stuff. They tend to be the kind of person that needs to have analyses presented to them, needs to have advice presented to them. So they tend to work through tools and analyses, products, services, in order to get the information they need in order to make decisions. And of course, those tools and products and services and analyses get based on data that is collected and stewarded by other organizations. And sometimes those organizations, sometimes that happens in a single organization, but we're more interested in the situation where those are very different kinds of organizations, where we have some organizations that are stewarding data, that they share that data more widely with a range of organizations that can create different kinds of products and services that suit different kinds of audiences. And therefore, we manage to reach a broader set of decision makers that can make use of data. But all that requires us to have data stewards, people who are collecting data that share it. And we see two kind of threats to the way that might work well. The kind of data hoarding threat is where, because people are being told data is oil, it's therefore really, really precious, they think that they have to hug and hold on to it. What we find is that we get strong in-organization data use, but less use in that broader sense that I was talking about, of that range of different intermediaries, a range of different decision makers. And that means that they can only address very narrow decision maker needs. We have a restricted market of intermediaries, a restricted set of organizations that can create those products and services, when we could have a lot more innovation, a lot more economic growth, if that's a vibrant part of the data value chain. And we also see this kind of data extraction mode where more and more data is collected because it's oil and therefore useful, right? So there's a threat that restricts the overall value that we could get from data being more widely available. And we argue that we should have more openness about data, more broader sets of capability across a broader set of people, and purpose-focused innovation in order to get data being driven towards impacts that you want to have. Now, I think that story is very familiar with most of you in the room, so I'm not going to go into that in a great amount of detail. I think this story is also probably familiar to you in the room. The other threat is that we get concerned about the way that data might be misused. We start to worry about and drive fear around the way in which data might impact on people. And that can lead to not collecting data that could actually be valuable, not using data that could, in ways that could be really impactful. We see withdrawal of consent not only at an individual kind of level basis, but also at a collective, a community or a nation or level basis. So we start seeing regulation, legislation that stops us from using data in particular ways. Can mean that people provide data that's misleading. One thing that's bubbling in my mind is, to what extent is the current narrative around data going to affect things like the census? Are people going to because they're so used to lying on online forms, are they going to lie on the census? And all of those are threats to what kinds of conclusions we might reach when we are using data. So there's this strong threat around when we get into a situation, an environment, a culture where we fear the way in which data might be misused. And that means that building trust in the use of data is incredibly important, and that's what I'm going to mostly focus on. So trust is really important. How can we retain it? First point I want to make here is that fear and distrust is infectious. Even if you are doing fantastic things, even if you are completely trustworthy as an organization, trust in you will be affected by the way people feel about other organizations in your sector and that you work with. And one of the big threats around that is that there's a huge amount of general distrust in the way in which personal data is being used, a huge amount of distrust in big tech. In most surveys that I've seen, the proportion of people that trust big tech to use data well is about 4%, which is incredibly low, right? And there's also this kind of, especially in the kind of world that you work in, this general narrative around NHS privatisation, the role of the private sector, who benefits, et cetera, et cetera. Have to take that into account when we're looking at work around trust in this sector. Second point I want to make is this distinction between being trusted and being trustworthy. So being trusted is about, how people feel about you as an organization. Being trustworthy is whether you're actually doing things in the right way, right? And what we find is that there can be a big mismatch between those two things. Untrustworthy organizations nevertheless being trusted, perhaps because they don't let on about what they're doing. It's not so visible about what's going on. But similarly, trustworthy organizations not being trusted because they've communicated poorly, or they haven't quite engaged in the way that their audience was expecting them to. And getting that alignment between the degree to which you're trusted and the degree to which you're trustworthy is one of the big challenges we have just generally in the data ecosystem kind of world. So a couple of frameworks or ways of thinking about this. First comes from some work that we've just started, so I can't give you huge amounts of insight in it, but that looks at the kind of theoretical frameworks around trust and how trust is built and won and lost. And that's identified 4 main points of failure. One, where people misunderstand what you have said about what you are doing. So misunderstanding point of failure. One where you have misrepresented what you're intending to do. So when you don't do what you say you're going to do, that diminishes trust. Not providing updates when the situation changes. So it is always the case that context changes, the environment changes, you learn as you go, and those changes may impact on what you do, but you need to be communicating those changes to the people that you want to win trust from. And the final one is around lack of information. Lack of information for either you as an organisation to be able to make good decisions, to be able to know what it is that you can do, what your capability is going to be, in order to make promises that you can keep, or lack of information from the point of view of people who are looking at you and trying to work out whether to trust you or not. So these are the things to watch out for in your kind of communications, in the way in which you engage with people in order to not lose trust from them. The other framework that I'm going to talk about is this framework, which is really based on just an observation of the places where people seem to be falling down around being trusted and trustworthy. And that's a kind of Maslow's hierarchy of needs or whatever around building trust. At the base level, there's compliance, then ethics, engagement, and equity, and I'll talk through each of these. So compliance, this is hygiene factors, right? Protecting personal data, complying with the law, complying with codes of practice. That's fundamental stuff that you need to get right. Not having breaches where you lose data on the train, on some USB stick, right? Stupid stuff. Privacy, basic privacy and security. But you can do that right and you can still not be trusted, okay? There's a huge amount of talk, huge amount of focus at the moment on ethics, but I only count that as the second layer in how to build trust. Being open and transparent is an important part of doing the compliance bit well. Publishing ethical principles, so the HDR UK DIH principles of participation have some of this in it. Publishing those, saying this is our intention, this is how we're going to work. Lots of organisations are publishing those kinds of ethical principles for how they say they're going to work with data. There's then actually doing compliance well. So you can comply with things like, I don't know, GDPR in general, or data protection in particular domains, or particular codes of practice in a kind of tick boxy way. Or you can do it well in a way that is really transparent and involves people, that you actually test the way that the interfaces work, that you lead them through and understand whether they understand, right? So you can do compliance well, you can do it poorly. Doing it well is part of this layer. And then not only having those principles kind of out there in the world, sorry, I wave my hands around too much, principles out there in the world saying this is how we intend to behave, but actually embedding that in the way in which you practice in your organisation, the development of different tools, or perhaps the kinds of ways in which you make decisions about data access or data architecture. So embedding those practices, going beyond just saying these are our principles, but actually what is the way in which you're embedding that into the way that you work. Now, I've seen organisations that have done all of that and that still are not trusted by people. So what is it what's the next kind of layer? Well, the next layer is things that you have been talking about, I gather, a lot today. So how you engage with people. And here I see different kinds of patterns. So it's very common to have advisory boards, ethics groups, and so on. Having some external people who can look at the kinds of work that you're doing and give you advice on them. You can also do very proactive outreach to communities who are affected by the way in which you use data. Ask what they think. Where it becomes a bit more challenging, and it takes a while to get there, is to actually act on what they say, take what they say and do the things that they imply, and even more challenging, give them some veto power. So actually making that switch from just asking their advice, which might be ignored, or to giving them actually some authority to make some decisions. Now that flip is a very challenging one for organisations, because it means that they're no longer completely in control over what they can do. But it's that flip that, or rather what I've seen without that flip, that people undermine the way in which the engagement is done. So I think that this is, like I say, an extremely challenging set of things to do. I don't think it's something that you can leap to immediately. I think it's something that as organisations you need to evolve towards. But I think it's quite important to have an aim to get there. Now, I've seen organisations that have tried to do that, and still they are criticised, and still people are concerned about the way in which they use data. And that leads me on to this final piece, which is about equity. And this, I think, is the most challenging set of things to do. Equity is about how the value of the use of data gets spread between communities, between different kinds of organisations. And describing those revenue models, describing value return, is part of showing that you are being equitable in the way in which data is being used. Ensuring equity in who benefits, so spreading out the way and examining who is getting to benefit from the particular decisions that are being made. And building into the kinds of corporate structures or the organisational structures that you're creating a drive towards equity rather than a drive towards, say, profit, is one of the ways in which you can help to reassure people. Again, the hardest level, and particularly hard level when you have organisations, when a data access piece of the organisation might be only a small part of what an organisation is doing, when there might be a whole set of other things that are going on that undermine the way in which people think the data is, whether people think that there is equity in the way in which data is being used. So I hope that's helpful as a kind of hierarchy or way of thinking about the different levels in which you need to go through in order to build that trust. We've been looking at ODI in particular at these, thinking about in a way those last points, what kind of institutions do we need in order to provide some of those guarantees around equity? We've been mapping different kinds of access models. This is our data access map with some puns on it that if you get close enough, you'll be able to see. And right in the middle, there's an island called Collaborador, which is all about how organizations collaborate to share data and get the most out of it. And that in the middle there are a bunch of particular types of organizations that we think are really interesting, what we call data institutions. Data institutions are there to increase access to data. That's part of their purpose, and ensure that the benefits of data get shared more widely. They are important intermediaries because they can balance these conflicting views and incentives and priorities of both organizations that have data, organizations that want to use it, and the people and communities that are affected by its use. And being able to balance those three sets of communities is part of what makes an institution really important. You can also use them to reduce the cost of data stewarding because they can provide a kind of common service, which means that you don't have to have the same costs in lots and lots of different organizations. There are multiple types. We started off by looking at data trusts at ODI, in part because they were mentioned in the Hall and Percenti AI review. Data trusts, which is at the bottom there, really inspired by the notion of legal trusts. They have particular kind of architecture where you have trustees that have fiduciary responsibilities for the way in which data is shared. But there are also other kinds, data clubs where just organisations get together and share data between each other. Commons where you're thinking about it as a common resource that multiple organisations are maintaining. Or cooperatives, a model that lots of people are very excited about but I haven't seen working in practice yet, where lots of individuals pool data together into a cooperative, and then the governance is based on the membership, right, of the same individuals that are pooling that data. So inspired by kind of mutual organisations. These are all different forms, and I'm sure that there are other forms as well. At ODI, two of the big questions that we're looking at is how do we help those organisations be both trustworthy and trusted? What kinds of external things do you need in order for that to happen? Whether it's accreditation or certification or insurance, other kinds of external things that can help organisations prove their trustworthiness. We're also strongly looking at sustainability and how do you create revenue models, business models that enable organisations to have longevity and be reliable while not working against their purpose, which is ultimately to share more data. So those are particular questions that we have. So I've gone through data value chain, how we get impact from data, importance of trust and how to retain it, these kinds of emerging institutional models for trustworthy access. Just as a final thing, I think that you guys who are working, particularly in the data innovation hubs, are really showing the way for how we can do this well, and experimenting and trying out different kinds of models and different kinds of approaches for engagement, different types of models in technology and in access are going to be incredibly important, not just for the health domain, but also across lots of other sectors. So congratulations, keep doing it. Please share what you are doing so that we can all learn from it. That's it. Thank you very much.
So we have got time for questions. First of all, obviously, a very big thank you. And being sort of chair of this session, I'll get to ask the first question. So who is doing it well?
Oh, God, I hate questions like that. So the institutions that I have seen that seem to be successful, I think are ones where you've actually got some kind of political and legal mandate to do data collection on behalf of some set of other organisations. Those are the ones that I can see in existence that are able to function in a sustainable way, right? But most of those don't tend to be ones that are dealing with personal data from what I have seen. And I think that, I think on personal data, then you can see pockets of good practice. But as I say, we're all experimenting and we're all learning. And my observation is that none of us have quite got there yet to the nirvana of everybody saying, oh, yes, not only do I know everything about what you're doing, but also I approve, right? That's just some way off.
Thank you. I won't hold the questions. I'll open up the floor to...
Hi, Charlie Hooper from the DigiTrials Hub. You talked about sustainability. Can you help us understand that too? So have you got anything you can show us on the sustainability yet?
So that's a project that we've just started digging into. It's based off a lot of what we have learned from sustainability around open data and open data business models, because obviously they need to promote data access but still have some sustainability built into them. The one crucial tip is to really make a distinction between providing access to data as a fundamental thing and providing services on top of that access and charging for services but not charging for licensing. And making that distinction tends to unpick some of the other tensions that you might otherwise have. But reports should be coming out roughly end of March-ish on that.
So Andrew, then Caroline.
Terrific talk, Jane. Congratulations for taking a very complex topic and making it so accessible. Privacy enhancing technology. Can you horizon scan, 5 years down the track? How do you think technology will be enabling for this agenda?
Okay, so I think that there are a few areas in privacy enhancing technologies that are incredibly powerful and exciting and that we should be exploring more, particularly around synthetic data and distributed, oh God, I can't remember, like distributed machine learning, basically, where you put out your request to the places where the data is held and you get back the results of that and combine it, right? Those are incredibly useful ones. And I'm sure that people at Turing in particular will be exploring a lot more of those. I think that where we still need to have work, though, is in explaining those to the people who are actually being affected by the sharing of data, in particular, the people who are mentioned, because there's not much difference for somebody who is whose patient record is being used, whether that data actually goes from one place to another or not, right? For them, they just care that it's being used. So how we explain the fact that these privacy enhancing technologies actually provides them with an extra level of protection, I think is a challenge that we need to address too.
I thought your, sorry, Caroline Cake here. I thought your kind of hierarchy of trust was really interesting, really helpful. What aspects of it do you think we should think of as a system level versus individual organisation levels? And I don't know just how your thinking's kind of developed on that.
So the way that that hierarchy was very much certainly based on individual organisations and what individual organisations should do. The work that I mentioned near the end, where I was talking about how to provide that kind of enabling infrastructure that helps to identify whether organisations should be trusted, or that I think is a more system-wide kind of intervention. So. I talked about the kinds of new institutions that we might find cropping up to help us to be those intermediaries for access to data. But I think that there's a whole bunch of different kinds of services that are going to need to be provided, perhaps by existing organisations. So by professional societies, by insurance companies, by auditors that provide for that more system level assurance over the way in which data is being handled, if that makes sense.
Thank you.
Hang on a minute, Tim. Just wait.
I mean, the privacy advancing technologies, they're highly technical. Do you think you're ever going to get the public to, it sounds just like a good way of bamboozling them. I mean, is there any way of solving that?
So that was my point about communication around them, that I think that the way in which we need to find good ways of providing a simple but not misleading narrative about the way in which privacy-enhancing technologies work. If I point to the work that's done by Understanding Patient Data around explaining anonymization, right, where you've got like pictures that help to explain those things, that's the kind of level of stuff that I think that we're going to need to develop around those kinds of technologies that we were just talking about. I think we can get there, but like I say, I think we need to have some work on it.
Any closing questions? That's it.
Thank
you
you
very much indeed. Okay, you'll be pleased to know it is now the wrap up and close. I certainly can't follow that, so I've got, I think, 3 things that I'm aiming to do here. Firstly is give you my very quick take of the day in words, but there's only about 5 of them. So trust, 5 safes, deputy dog, Coronation Street, quarterbacks, and data hoarding. Sort of sums up a number of these things for me. So I think hopefully everybody's taken a sort of vision away from today. I think one of the second thing is to really make sure that we now take the outputs of this and make sure that we don't add to the commentary, but actually what we do is start to turn these into products, take the ideas into products that are then scalable, using things like the Innovation Gateway, but that's just one example, but how we really turn this into action and not just more commentary. Our act on that will be making sure that we bring together the outputs of the different sessions. The table's been asked to provide a sort of brief summary. The workshops obviously can feed back into that, and that can help to shape the work plan for this year and beyond. And so that's a sort of commitment to you. We'll obviously share those outputs not only with those in the room, but those who weren't able to be in the room as well. The final thing is a big set of thank yous. I think first and foremost probably to Fran and the team for all the work that Fran's done. I don't know if Fran is around or whether she's now hidden herself. But obviously these sorts of things don't happen easily or don't happen without a lot of effort. And Fran, Kieran, Sindhuja and others put together a fantastic sort of event for us. And I'm very, very grateful to them for that. Also very grateful obviously to the Wellcome Trust, not only for hosting us generally, but today as well. The AV team, food, receptionist, again, helping these things to run really smoothly. And finally to the presenters who have come along and to yourselves for obviously participating today. Very much appreciate it. It's an absolute sort of pleasure to have been part of the Alliance for this journey so far and very much enjoy looking forward to the journey forward on that. So with that, I will close this and allow people to sort of mingle over refreshments. Oh, hang on a minute, I haven't. There's one last, the photograph. Sorry, yes, you're not allowed to escape before having a photograph taken. Not an individual one, but a group one.
Yeah,
Caroline.
so as this is our kind of inaugural session of bringing everyone together, you guys are the first. So in years to come, when this has evolved into 10 years, 20 years time, you can be there. I was there at the first of them. So this corner, I'm kind of gingerly looking over here to see where Caroline, the photographer's gone. Very lovely, lovely. Does that work? Yeah. Brilliant. And then we'll just bundle over here and then drinks.
So get in quick before there's 80,000 people in Barcelona.